See
Yes,
you.
the boss.
Good. Shomo,
Good evening, sir. How are you, sir?
hello to you. Thank you so very much. So Ajit is around.
Yep.
Uh, so maybe I will formally declare it open. So it's about 5:59. All right. So ladies and gentlemen, good evening, and welcome to this third EP Fellows Summit. I am quite grateful to all the faculty from India and abroad who have been consistently encouraging us to hold such programs for the last 3-4 years. We have as many as 20 faculty who have taken the role of the moderators. Today we have 10 presentations by the brilliant cardiology residents and the EP fellows. I congratulate all of them. All the presentations I had this privilege to go through are fantastic. Each one of them deserve a great applaud. And in fact, they each one of them had won cash prize of 10,000 rupees. I would like to declare. Anyway, Ajit Tachil is around. He is one of our moderators today, and Anil Saxena, Dr. Anil Saxena must also be joining. Dr.
Yes,
Anil,
I'm already there.
Dr.
Yes.
Anil, a warm welcome. You have been consistently supporting our program for the last 2 decades. It is
I
such a
might
privilege.
get cut off for 2 minutes. I'll rejoin. Yeah, thank you.
No problem. No problem. So,
Thank you, sir.
there are certain announcements I would like to make, especially to the presenters. Each presenter is given 15 minutes for presentation. That will be followed by 10 minutes discussion among the participant and the moderators. And the audience can put their questions in the chat box, and it will be at the discretion of the moderator to take up that question or no. But you please put up your question. And to adhere to the time limit of the presentation, the presenter is going to be alerted twice. Once 2 minutes before the completion of the presentation, and another 30 seconds before the end of the presentation. So again, I welcome the moderators, and again, I would like to express my gratitude to all those moderators who have joined in, who have taken the time out on a Saturday evening. I congratulate the presenters. So let's begin. So let me invite Dr. Suresh Kumaran. He is the fellow from JIPMER Pondicherry. His mentor is our friend Raja Selvaraja, an accomplished, very well-learned electrophysiologist who happens to be the editor of Indian Pacing and Electrophysiology Journal. He had been always kind of a friend of our EP department. He had guided us through. So thank you, Raja Selvaraja. You have made some of your fellows to present their cases. So welcome, Dr. Suresh Kumar.
Good evening, sir. Yes, sir.
Open the presentation.
Yes, sir. Am I audible, sir?
Yes, you are.
Yeah. And my screen also, sir?
Yes, yes.
Yes. Good evening, respected professors and everyone there. So I am Suresh Kumar, doing a fellowship in JIPMER Pondicherry, and I'll be talking about a case. And this is about a 60 years female with recurrent palpitations, and which was adenosine responsive and with a structurally normal heart. And this is a tachycardia ECG. This tachycardia ECG shows an narrow QRS tachycardia with a heart rate of around 188 beats per minute with the short RP, and the P waves are inverted in inferior leads with normal QRS axis, and there is also ST depressions in V3 to V6. So if you look at the RP interval, the RP is around 120 milliseconds. That is, RP is more than 90 milliseconds. So with this, we have a differential of atypical AVNRT, AVRT, and also atrial tachycardia. The sinus ECG did not show any pre-excitation. And so we went ahead with the this electrophysiological study. And after the baseline measurements, then we went into the ventricular burst pacing as well as the extra stimulus protocol. And while doing ventricular extra stimulus protocol, the tachycardia got initiated, and with the VA-AV sequence, and with the tachycardia, initially there was a wobble in the tachycardia cycle length, and there was also a wobble in the VA interval also, with a delta VA of around 20 milliseconds. And so the earliest atrial activation was around it was in the His channel, and we could see in the fluoroscopic corresponding fluoroscopic image in the right side, and the CS was around between CS 5, 6, and 7, 8. So the tachycardia, as the tachycardia continued, the tachycardia cycle length got relatively stabilized. The VA interval also got relatively stabilized with around 120 millisecond. AH was 184 millisecond. And comparing the atrial cycle length and the ventricular cycle length, we could not predict that which precedes which. So at this point also, we have all the three differential diagnoses. And we went ahead then with the ventricular overdrive pacing at 20 to 30 milliseconds shorter than the tachycardia cycle length. And so with this, we are pacing at 340, but we could not entrain the tachycardia. We were unable to entrain, and we were unable to entrain the atrium on isoprenaline also. So since we were unable to entrain, so this essentially rules out AVRT, and we are left with only two diagnoses as atypical AVNRT as well as atrial tachycardia. So then we actually proceeded with the atrial pacing, and we compared with the tachycardia, that is the tachycardia AH as well as the atrial pacing at tachycardia cycle length during sinus rhythm. So we compared the AH during atrial pacing at tachycardia cycle length during sinus rhythm as well as the AH during tachycardia, and the delta AH was around 27 milliseconds. So if which was borderline, so this delta AH, if it is more than 40 milliseconds, it would suggest AVNRT, as because during tachycardia, that is during AVNRT, the antegrade and the retrograde conduction, that is the antegrade conduction through the pass pathway and the retrograde conduction through the upper common pathway is going to be simultaneous. Whereas in pacing, it's going to be sequential. First, the upper common pathway, followed by the fast pathway and the lower common pathway. So the delta, so the DAH during AVNRT is going to be much smaller compared to during that pacing. So the difference is going to be higher in AVNRT, whereas it's going to be less in AT. But with this maneuver also, we had a borderline inference. So we could not differentiate at this point also. And then we proceeded with a response to adenosine, which we tried to confirm it. And with adenosine repeatedly, there was a cycle length prolongation, atrial cycle length prolongation towards the end, and they terminated with V consistently. And so with at this point also, we could not differentiate between the atypical AVNRT or an atrial tachycardia. And atrial burst pacing actually was repeatedly terminating the tachycardia. And so hence a VA linking differential side atrial pacing delta AH during SVT could not be verified. So we were left with another option, that is the simultaneous atrial and ventricular pacing. So this is, we are pacing both the atrium as well as the ventricle simultaneously, so that we are going to engage both the atrium and the ventricle at the same time. So when we stop pacing, then the first EGM is going to arise close from the source of arrhythmia. So that is going to be a His in AVNRT or atrial EGM in case of an atrial tachycardia. So in this, we got the first intracardiac signal as His, suggesting AVNRT. Just looking into the mechanism again, like this is a ladder diagram, simple diagram showing simultaneous atrial and ventricular pacing. And so this is during the tachycardia and with simultaneous atrial pacing. And once we stop, like it's going to go through the slow pathway, and it is going to continue as the tachycardia with the hiss as the first signal. And during atrial tachycardia, after stopping the atrial and the ventricular simultaneous pacing, the first EGM is going to be from the atrial focus itself. So the first EGM is going to be atrial. And so the first time we got a hiss as the first EGM, and we thought it was AV and RT. But when we repeated again, then we got actually atrial EGM as the first electrogram. And so hence this put up into a dilemma again. And so this could have been explained by an additional AT with an additional dual AV nodal physiology underlying. So the last atrial pacing could go through the slow pathway and could produce the hiss as a first signal, even in case of an atrial tachycardia. But this actually depends upon overdrive. It's not all the cases are going to get hiss. It will depend upon the overdrive suppression of the atrial tachycardia. It could depend upon the refractory period of the slow pathway, or it could depend upon the refractory period of the AV node, or it depends upon the site of pacing also. Like CS pacing is going to produce a shorter AH. So with all these, what is the diagnosis at this point? Initially, like still we are in a we are not able to differentiate. So the points favoring AV and RT are initiation with a ventricular extra stimulus. That is with ventricular extra stimulus, like that's it's very uncommon to initiate AT because it will have to conduct retrogradely through the AV node. That will be a decremental AV nodal conduction, and that will not give sufficient prematurity for atrial activation. And the first EGM after simultaneous A plus V pacing was once his signal. And termination with adenosine with V, although it does not differentiate, it does not rule out AT also. And the points favoring AT are the first EGM was once atrial EGM. There was a wobble in tachycardia cycle and VA at the initiation of the tachycardia. There was a VA AV activation sequence with induction. So still we were not able to 100% confirm the diagnosis. So we were left with the option of slow pathway ablation or a mapping and ablation of the earliest focus of AT. So the earliest focus was in the His channel, and therefore the paraisian region. And we were thinking whether to take the risk of ablating near the AV node and take the risk, or to go for slow pathway ablation, as we are not sure at this point of time. And we are left out with all the manuals. So the next we did actually slow pathway ablation, but we got good junctional automaticity. And but after slow pathway ablation also, the tachycardia was easily inducible, and the atrial cycle length was similar, and the atrial activation was earliest in the His channel, like a similar one. Whereas there was tachycardia with A more than V, that is with a 3:2 AV nodal Venki back, probably because of the slow pathway ablation itself, because the fast pathway is not able to conduct as it has a longer refractory period. So next we went ahead with the mapping for the earliest atrial focus, that is from the right supraparaseptal region. And we got the earliest atrial signal 33 milliseconds earlier than the P wave onset, and in the right supraparaseptal region. But there was a significant and a big His potential there. So we thought we would go next is retrograde and map for the RCC. And while mapping in the RCC region, we got a good earlier than the P wave onset, and with ablation, that is with the initial burn, the RF, the tachycardia terminated immediately, and it was not inducible thereafter. And there was also no His in this area, and the post ablation PR was also normal. And like so, considering all these, that is this initiation with the extra stimulus and termination with the atrial pacing, then also responsive to adenosine, as well as non-entrainable tachycardia. This all suggests a triggered mechanism of parisian atrial tachycardia. And a patient came after 6 weeks of the follow-up, and she did not have any recurrence thereafter. So with conclusion, this narrow QRS tachycardia, which are not entrainable by ventricular overdrive pacing, leaves us with a differential of AT versus AV NRT. Atrial overdrive pacing to look for VA linking a different cycle length, different durations, and different atrial sites will be useful. In this case, we also did a simultaneous atrial and ventricular pacing, but no single maneuver can differentiate between these two when the ventricular overdrive pacing fails. We must use a collective information to make a diagnosis.
Thank you, Dr. Suresh. May I request now Anil Saxena and Ajit Thachil to lead the discussion. I am not seeing Abhishek Deshmukh. Abhishek, are you around? Dr. Abhishek Deshmukh, who is a renowned cardiac electrophysiologist from Mayo Clinic, Rochester. Maybe he would be joining us a little later. May I request Anil Saxena and Ajit Thachil to lead the discussion,
Sure.
please?
Yeah, thank you. Thank you. I think that was an excellent case presented by Suresh. Suresh, was any dual physiology apparent on the EP study?
Like
VA
with the atrial
AV?
extra stimulus, actually the tachycardia was repeatedly inducing, sir. We could not conclude with
But
that.
was it inducing with a jump or
No, sir. It was
any?
starting with a
interval?
drive train only, sir. Drive train. Even with the drive train, it starts and then it stops.
Okay. One more maneuver has been described where you place the catheter in the, during tachycardia, you place your catheter in the slow pathway location and you give a APC. And if that terminates the tachycardia, that goes in favor or very strongly in favor of AV NRT. Not only, it also identifies the slow pathway location where you can give a burn safely. So that is one thing which can differentiate between AT and AV NRT in difficult cases.
Okay, sir.
Ajit, your comments, please.
Yeah, Suresh, I think you meant to say NCC, right? Rather than
Sorry, sir. NCC.
Catheter was obviously in the NCC.
NCC. Sorry,
Yeah.
sir. NCC.
Yeah, so that was NCC. That's fine. The other thing, two things I'd like to mention here is when you were pacing the V and the A were dissociated during the tachycardia when you
Yes,
were
sir.
trying to entrate.
Yes, sir.
Now, at that point, one thing which could be helpful is trying to do that at multiple cycle lengths. Did you do it only at one cycle length or multiple
cycle lengths? Multiple cycle
And
lengths,
you
and
were
also
always
we tried
dissociated.
dissociated. We also used isopentanol also, sir.
All cycle lengths dissociated.
All cycle lengths were
Yeah,
dissociated.
so that is one other thing which is in favor of atrial tachycardia. If you dissociate at multiple cycle lengths, which of course are just 10 millisecond different from each other, that is once again in favor of atrial tachycardia. And the last thing I'd like to mention here is that the A you had in the HIS, unfortunately, was a sort of far field A. So probably that's one thing which could have been looked at, that understanding that the early A was in the HIS, like you said, but it was actually a far field A. So probably it would have made sense to try for a near field A in the HIS, or even map the NCC before deciding on ablation. And finally, like Dr. Anil Saxena said, I would ablate these tachycardias during tachycardia. Abhishek.
Okay. Yeah.
Yes.
So we
Can you
also
hear me?
did during tachycardia that was tachycardia also terminated. Just
No, your first burn was a slow pathway ablation during
Okay.
sinus.
It was during sinus. Yes.
Yeah. So Abhishek, your comments, please.
Yes, fascinating case. If you look at the initial history, initial ECG, and if you look at the P wave, it was initial negative and terminal positive. So if you look at the sinus P wave, normally it is initial positive, terminal negative. This is flipped. And whenever the P wave flips like this, it is neither too positive nor too negative. So it's in somewhere in the middle. So that itself becomes a clue that this is kind of a paraseptal tachycardia. All your maneuvers were fantastic. And, some of the maneuvers what you showed, and even the Sarkozy maneuver where you can pace from different sites in the CS atrium, lateral left atrium, and look at the change in VA interval can be diagnostic. Now, your approach was absolutely the way I would do it. If you don't know what you're doing, then you start to map and find the earliest A, because then it becomes like playing a treasure hunt kind of a game, and then find it on the septum the way you found it. And then, developing that near field signal, which you did not get it from the right side, then you went retrograde and found the near field signal on the non-coronary sinus. I think that was very nicely done. Now, assuming you are unsuccessful there, what would have been your next step?
In NCC, sir.
Yeah.
Then we would have gone to the anteroseptal LA. LA we can go. We can also look in, sometimes it's described that it can be in the RCC, it can be in the LCC, it can be in the iotomitral continuity also.
Yes. So RCC will be a little bit unusual because you don't get much of atrial tissue there. But certainly mapping, going transseptal and mapping the superior anterior mitral annulus can also be kind of a vantage point where you can see this tachycardia. Now, did you have 3D mapping or just point by point mapping? 2D mapping. So that's fantastic. If you have 3D mapping and you're trying to look at this tachycardia, you would not be able to actually differentiate AV-NRT from ATAC, because in AV-NRT, majority of the circuit is going to be in the AV node, so you're going to miss out on a lot of tachycardia cycle length, which is practically the AH interval of the tachycardia. And AV-NRT map will always look like a focal source tachycardia exiting from the fast pathway. So both these maps will look very, very similar. So doing 3D mapping from knowing the earliest breakthrough site would help, but doing 3D mapping to understand the mechanism of arrhythmia will not help in this kind of situation. So great job and congratulations.
Thank you.
So I think we should move to the next presentation.
Thank you.
I think Dr. Narayan Nambudiri has been commenting in the chat box. The audience are encouraged to go through the chat box. There are going to be comments from the colleague groups and the moderators and the experts like Narayan Nambudiri. Well, it's my pleasure now to invite a foreign resident from Texas. Her name is Netu Salagunda, and she is a chief Fort Worth, Texas. Senthil, a friend of ours who is her mentor. Welcome, Netuja, and you please present your case.
Thank you very much. Thank you everyone for giving me the opportunity to present. I will go ahead and share my screen. Oh. Sorry, I'm having some technical difficulty to share.
Ma'am, can we share your presentation, ma'am?
I am trying to share, but it's not letting me. Just give me 1 second. Can you all see the presentation?
Yes, and you can go to the slideshow mode.
Yes, sir. Okay.
There you go.
Okay. So the case I'm presenting today is a flutter. I have a patient here who is a 53-year-old male with a known history of non-ischemic cardiomyopathy with an EF of 20 to 25%, has history of smokeless tobacco use and atrial fibrillation, underwent vein isolation in March. During his follow-up visit in the clinic, he was found to be in 2-to-1 flutter. He was started on oral amiodarone, and 1 week later, he was scheduled for cardioversion. He underwent cardioversion and failed and presented since then to ER twice with persistent flutter, so he was scheduled for ablation in April. And here is the EKG, one of the earliest EKGs after the presentation. As you can see, it is a flutter with variable conduction. You can see the sawtooth wave patterns in inferior leads in 2-3 AVF, suggesting it could be a right-sided flutter. He later was more in 2-to-1 conduction, as you can see, 2-to-1 flutter. On the day of presentation, he presented in tachycardia on the surface EKG with a cycle length of 283 milliseconds. The case approach was to place a CS catheter to confirm the atrial activation sequence, left-sided or potentially right-sided, and also to perform left atrial mapping with high-density catheter for potential vein retouch-up, a redo AFib, and also further to confirm circuit confirmation and ablation strategy to be formulated. Here, we place the CS catheter, as you can see. The tachycardia cycle length was 291 milliseconds. It is a 2-to-1 conduction, and proximal being the earliest suggests this still could be a right-sided flutter. We went ahead and did LA mapping with high-density catheter, as you're seeing here. The 3D mapping with the local activation time map. When we were mapping on the left side, we were seeing more red and yellow colors, but once we mapped more towards the right-sided veins, we could see all the colors coming into the play. So this is the local activation time mapping, as you can see, which is represented by sequence of colors. The color sequence can tell us both the direction of the wavefront and also the speed of the wavefront, which can further be confirmed with the OT vectors, the directionality, as you can see here. Local activation time mapping can also be used to differentiate whether it's a focal tachycardia versus a reentrant tachycardia. Each color in LAT represents same span of time. For example, if you see a narrow color like this, it suggests it's a slow conduction covering a very small distance. And if you see a wide color pattern like here, it suggests it's a rapid conduction covering large distance. And sometimes the early in reentrant tachycardias, the late always has to come and meet the early, completing the cycle, which suggests it's a reentrant tachycardia. Sometimes in the reentrant tachycardias, you can also see a focal epicardial jumps, like here, but the early always has to come and meet the late to complete the circle for reentrant tachycardia. The epicardial jumps sometimes can be tied into underlying anatomy. For example, Bachman's bundle or septopulmonary bundles. Bachman bundle is an interatrial bundle which runs in the anterior wall parallel to the AV groove, extends rightward to the RA and SVC, and laterally to either side of the left atrial appendage, which is more subepicardial. And this sometimes can be responsible for conducting the circuit towards the right atrium. Septopulmonary bundle, which is more epicardial fibers, which runs right beneath the Bachman's bundle, ascends the roof and surround the ostia of both left and right pulmonary veins, can sometimes be responsible for epicardial jumps of the circuits. Like the circuit here, as you can see, you can trace the circuit all the way from right superior pulmonary vein, coming down to the posterior, to the roof, anterior, towards the septal, coming all the way back to the carina and into the right superior to cause the activation. And it's overlying the anatomy represented here with the blue lines as septopulmonary bundle and purple as Bachman's bundle. Sometimes these can be responsible for focal jumps and Bachman probably conduction to the right atrium. We found, I think there's one more here. We found a clear breakout, a focal breakout, right at the ostia of the right superior pulmonary vein. As you can see, the vectors going in all different directions. There is also color compression band, as you can see, along the yellow and red, the orange. That suggests it's a very slow zone of conduction, suggesting a previously damaged or scar tissue. This could be a previous carina line done during the PVI. And we put in the grid there to see the EGM signals. As you can see, they're very fractionated high frequency signals at that site. So this was identified as possible isthmus for the flutter. And these are the EGMs on the GE. As you can see, very late activation and fractionated signals. And it was then decided to go ahead with the ablation at the site, which terminated the flutter tachycardia with first burn. Also recorded on the GE. As you can see, the ablation was started and 3 seconds later, the tachycardia was terminated. And this is a peak frequency mapping showing the site of interest was, the frequency was about 250, which was possibly the scar tissue responsible. So the case was terminated with flutter termination, right-sided walkout, touch-up was performed, and veins were isolated, posterior wall was isolated. Patient was followed up in the clinic, and patient has been arrhythmia-free since the ablation. The interesting thing about this case is it was thought to be probably a right-sided flutter, and as you can see, it ended up being the left-sided flutter. And we were able to achieve a first burn tachycardia termination. And that concludes the case. I
Thank
put in
you,
a
Dr. Nituja. Stay back. I hope it's convenient for you to stay back here for the discussion. What is the time there now?
It's early in the morning, 7:30.
All right. So I know that you must be rushing to the hospital today.
No, today is Saturday, so I do
Okay.
have.
All right. So hang on. You will learn lots, and the great case, and let the discussion begin. I invite the moderators to start the discussion, please.
So Nituja, great case and nice example of kind of an atypical flutter after an AF ablation. So a couple of points, the first ECG, what you showed, people who love ECG, they would pick up on multi-level AV block, which you can get in setting of flutter. So if you go back on the ECG later, you'll see kind of a group beating pattern on the flutter, more from an academic standpoint. But, from procedural planning standpoint, if your proximal CS electrode is early, it doesn't always mean it is right atrial flutter and doesn't always mean it is a left atrial flutter, because that electrode is just sitting there and looking at all the wavefront the way it comes there. So you can have a counterclockwise flutter where the proximal CS might be early, and you can have a clockwise flutter around the tricuspid valve where the activation sequence would be different. And same thing for mitral. So just focusing on the CS activation sequence may not be always ideal. But I like your approach that, as the patient was in flutter, you did a multi-electrode mapping, found out the slow zone. All the information what you get by these arrows and vectors is basically trying to explain to you the same physiology, that there is area of slow conduction there, and I'm glad you were able to ablate and isolate that. Now in the carina where you had that signal, any precaution you would suggest to our audience about checking for phrenic, or were you just too excited to ablate there?
I would probably. Sorry, what was the question, Dr. Deshmukh?
So in the carina where you ablated, below the
Yes.
right superior pulmonary vein, there is also phrenic concern for phrenic damage there, in the right-sided carina. So, obviously when we see a juicy signal like that, we would always like to come on ablation and see how it goes. But did you think about checking for phrenic nerve?
We usually, sometimes we do check for phrenic. Now, in this particular case, we did not, but
Okay.
we do check for phrenic, and then we do watch out for bradycardia sometimes. But in this particular case, we did not.
Okay. And the other question is, when you, how much of the right-sided veins were reconnected?
It was not a lot. It was
Okay.
it only needed a few touch-ups, but not a lot. Very minimal.
Because, because I'm glad you re-isolated the veins as you show, because, you could have one gap, but if you have more than one gap, you can still maintain a circuit of a different flutter. So I think the good thing would be to re-isolate the veins. And a lot of times with that out itself, that flutter may terminate because it is using one of the gaps in the line, but, or just find the best signal what you had and ablate. So great case, congratulations.
Thank you very much, Dr. Deshmukh.
Great case and great demonstration, Dr. Nituja. I just want to ask you a couple of things. One is about the peak frequency map, and two is about the color. You had some gray colors in that map. Were those gray colors because you set the frequency to 250, or because you put a low voltage ID more than 0?
The peak frequency is the setting that we put in the mapping to identify only above the 250 signals.
Yeah, so were those areas gray because you put the low voltage ID to more than
Yes.
0?
Yes, sir.
What low voltage ID did you use and why?
I only know that we
It says 0.09. Yeah, it's there. The low voltage ID is just above the emphasis. It's 0.09. So it didn't make any difference in this case, but probably when you're dealing with very diseased tissue where you have a hunch that the juicy spot is going to be in a very diseased tissue, it may be a good idea to put that low voltage ID at 0, especially because you have this peak frequency. If you did not have this peak frequency and you put the low voltage, the peak frequency is available only in the latest versions of Navix. It's not yet available here. But if you did not have this peak frequency and you put the low voltage ID at 0, then you sometimes get a lot of colors all over the place. But since you have this peak frequency, I would definitely go ahead and confidently put that low voltage ID at 0 so that you don't have all these gray colors. In your map, of course, the gray colors didn't make any difference, but sometimes the juicy spot can be inside the gray color. It can be less than 0.09. The second thing that I want you to discuss is, can you discuss some of the fallacies of using this peak frequency or using this number of 250? You use 250. Why 250?
This is I honestly speak, I cannot I am not an EP fellow, so I don't know much about peak frequency usages. I just put in the slide because we captured the frequency right before the ablation, but we did more with the activation time mapping and the slow conduction zone that we identified in the LAT more than the peak frequency. Peak frequency is
yeah. So if you're not an EP fellow and you've presented this case, fantastic. Even otherwise, it's fantastic. And if you're not an EP fellow and if you've done this, that's really, really good. So I just want to say that there's nothing sacrosanct about the number of 250. It's just that we believe that for this tachycardia, for this tissue, a frequency of 250 probably shows local electrogram. This whole business of peak frequency is thinking that, okay, near field will have higher frequency and far field will have lower frequency. But what is going to be the frequency of the near field for that tachycardia and that substrate? It is still, we still need to apply our minds to it.
Thank you.
No, great points. And, with the peak frequency, as you said, it's looking at far field and near field signal. But again, if it is such a multi-component signal, what she showed, on the thing, all these things, as you said, are not very well validated. So, if a mapping person is telling you this is where you have to go and ablate, it's not ideal. So you still have to, apply all the principles of EP as she did. So, but great point. Thank you.
Well, so Nituja, even though you are a cardiology fellow, your deep interest in electrophysiology must encourage some of the audience who are just the cardiology fellows who are doing their DM cardiology. And you actually have inspired, I think, many of the audience. Thank you for participating. And, my regards to your mentor, Senthil.
Thank you, Dr. Pandurangan.
So, ladies and gentlemen, we will go to another presentation. The same set of the moderators would be taking over this case. And this is Dr. Usnish Adhikari from Sri Chitra. I think he is very fortunate to have a mentor like Narayanan Nambudiri, one of the finest electrophysiologists from the country. I think he is logged in today, so he will also give some inputs in case the discussion becomes deep. So, Usnish, welcome.
Yes, sir. Am I audible, sir?
Yes, you are.
My slides are visible?
Yes.
Good evening, everyone. I'm Dr. Usnish Adhikari, Senior Resident DM at Sri Chitra, Tirunal. Today, I'll present an interesting case of lead noise due to perforated AICD lead. So I've modified the title slightly instead of what was presented. So our index case is a 50-year-old gentleman, Mr. A, who is a known case of Brugada syndrome with history of recurrent arrhythmic syncope. He also has a family history of Brugada syndrome, with his elder brother having type 1 Brugada syndrome with recurrent syncope and who underwent a AICD implantation. Our patient has got structurally normal heart. He underwent single-chambered Abbott AICD implantation in May 2023 in an outside setting. The lead details are given in my slides. It was a active fixation lead, 58 centimeters. Now he had come to us with history of inappropriate shock and therapy and pulsations over the left hypochondrium. So outside also he was evaluated and was suspected to have lead perforation. So this is the ECG, baseline ECG, which showed type 1 Brugada pattern with coved ST elevation in precordial leads. The imaging, that is radiography, pointed towards the diagnosis, almost clinched the diagnosis. So we could see in the X-ray AP view and lateral view. So the ICD lead is seen extending across the cardiac silo into almost, it is looking like it has gone into the abdominal cavity, with both the coil and the tip extending, looking like extending below the diaphragm. Even with the lateral view, we can see it is quite extra cardiac, it is present. Echo also showed the ICD lead that is perforated across the RV apex and extending across the pericardial cavity, but we are not able to visualize where was the tip end. So we interrogated the device, and the lead parameters were essentially normal. Normal impedance was there. Outside, in view of recurrent episodes of shock, outside they had disabled the therapy, which was pre-disabling. This was the therapy zones. Subsequently, we interrogated the stored EGMs. Now we can see in the stored EGMs, this is the near field EGM and this is the far field EGM. Both this near field and far field EGMs showed low amplitude, high frequency noise that was present in addition to the normal RV EGM, that is the normal sensed EGMs. So it was most likely during the straining phase, because it is seen consistently, and we can see that it was being oversensed in tachycardia as well as fibrillation zone. And the device had detected it as VF and given an ATP. And because the patient was evaluated outside, the shock therapy EGMs, he could not recover. That time it was interrogated. So we can see this noise that is seen both in the near field as well as the far field EGMs. Further, on evaluation, we saw that there was respirophasic variation. That is, this noise was exaggerated during respiratory phases, and it was more prominent in the near field EGMs. Here also we can see the respirophasic variation, but it was present in both the near fields and the far fields. And once it had detected this noise as non-sustained oversensed, but there was no therapy which was delivered. So in view of this, we had suspected myopotential from the diaphragmatic region that has been oversensed and inappropriately detected as tachycardia or ventricular fibrillation. So we undertook provocating maneuvers. So in deep inspiration, we can see that there was exaggeration of this low amplitude, high frequency noises. And it was present in addition to the RV EGMs. So that suggested that the lead might be still in contact with the ventricular wall or in the near the cardiac region. So in cuffing also, we could see there was exaggerated response, and these myopotentials were exaggerated. So with this, we had suspected the case of diaphragmatic myopotential oversensing. And we know that the low frequency attenuation filters, if we sometimes turn it off, it can reduce the inappropriate detection of this myopotentials. However, in our index case, though after turning the filter off, we could see there was some decrease in the myopotentials, but it was still present, especially in the near field EGMs. There have been several case reports and case series which they have treated this myopotential oversensing with turning off of low frequency attenuation. However, in our case, since it is mostly perforated lead, this troubleshooting maneuver was ineffective. So in view of all this, I'll discuss about this diaphragmatic myopotential oversensing, how we can identify this. So these signals have usually high frequency and low amplitude that we can see in our patient. And usually the oversensing begins late in the cardiac cycle, especially in the diastolic phase, where dynamic sensitivity is sensing is maximum, and any sensed R wave can interrupt this oversensing. And it is usually precipitated or exacerbated by forced inspiration, Valsalva, that is some provocative maneuvers. And there should be no evidence of any electromechanical interference or any lead malfunction, which we had already ruled out in our patient. With this in mind, we went ahead further for anatomical location of the lead. So this was the fluoroscopy in LAO view, which was showing the lead was extending quite deeply. We are not sure whether it was beyond the diaphragm. And in the RO view also, RO view also, we can see the lead has perforated and went into the phrenic region. So further, we went ahead with CT scan. And in CT, we could see that the lead, along with the tip and the coil, they were extending into the phrenic recess and had not gone beyond the infradiaphragmatic area. That is why it was capturing still the RV EGMs. And it was lying in the pericardial cavity. So we advised the patient for surgery, and he went ahead with the surgery. So on table, we could see the location of the lead that has extended across the RV apex into the pericardial region. It is almost touching the diaphragm that was causing this myopotential oversensing. So the surgeons, they used a pledgeted purse string suture to hold this lead and extract this. And subsequently, the PG as well as the lead were extracted. So currently the patient is doing fine and he is planned for reimplantation of the ICD. So my take-home messages are that identification of diaphragmatic myopotential oversensing is very essential, because this can lead to inappropriate therapy and can lead to inappropriate shocks as in our patient. And usually it is identified in the near field EGMs where we see low frequency, low amplitude, high frequency signals. However, far field EGMs can also show this myopotential, especially we see in our patient also, because the coil has also extended and it is in contact with the diaphragm. And careful analysis of the EGM and additional imaging, which we have done, that is CT as well as the fluoroscopy and X-ray, this clinches the diagnosis. Thank you very much.
Thank you, Shnish. So the moderators will begin the discussion.
Yeah, I was a bit surprised that RV signals were present. Was it in like integrated bipolar this thing, or committed bipolar lead?
It was an integrated bipolar lead.
That's why we could sense the RV.
Yes, sir.
I'm sure it was not capturing at all.
No, it was not. There was an electrogram there, I think, which
Exactly. Very, very interesting case.
The first thing I wanted to ask about the case, Dr. Saxena has already asked, why did it sense at all? Because it was allowed to sense from the coil using a integrated bipolar. Couple of things are regarding management. It's not directly related to this case presentation itself, about managing such a situation. One, why did you choose to implant the lead at the RV apex? Any particular reason? And two, was surgery your first go-to option or your standby option?
Sir, actually, this patient underwent ICD in an outside setting, sir. It was not in our institute. So post this complication only he had reported to us. And surgery we had planned because imaging wise, we were like the lead had extended across the RV and we were suspecting some perforation as well. So we were not sure we could extract the lead in the lab itself. So that's why we went ahead with surgical options.
I think that's a very good question from Ajit, because you see, these leads, after they perforate, after a couple of weeks, they form pericardial adhesions. And even when you pull back the lead, the pericardial collection is generally limited to that area. And most of them will not develop pericardial tamponade. And you can take it out, have echo machine in the cath lab, keep the patient on table for maybe 15 minutes, half an hour, see if it is collecting blood. And you can always put a catheter there, be ready for the pericardiocentesis. And if you find that the patient is developing tamponade, then you can take the patient to surgery. That would be my approach.
Okay.
No, great points. And I would certainly do the same as Dr. Saxena said, maybe pull it out and hope for the best. And a lot of times, as he said, these things get better by themselves. Interestingly, you did not have any tamponade on the one echo picture, what you showed, or any pericardial effusion. So that itself is reassuring. And if you pull back, I think it should be okay. But, just from the beginning, very nice summary of how you analyze the oversensing, cyclical, non-cyclical with respiration, coughing, Valsalva, and how it was kind of an extra cardiac source of, signals suggesting myopotentials from the diaphragm. Now, one opportunity do you think you missed that you already had sternotomy and you had access to the RVOT anterior surface? Any thoughts about doing epicardial ablation at the same time for Brugada syndrome?
Yes, sir. That is one possibility. But currently, like the patient did not have any further episodes of arrhythmia that was noted during the EGMs. Yes, sir. So rather than that, we went ahead with the device management.
And now, if you have to give feedback to the implanter, what would you tell him or her?
We would advise that rather than apical implantation, we should go for a septal implantation, and post implantation also we should carefully image and review on follow-up whether that lead is lodged or not.
Yeah, because if this was acute perforation, on the post-device X-ray, they should have picked it up, right? Because sometimes what can happen, the lead can also migrate over a period of time with each heartbeat as it is, traversing the pericardial space. So, whether it is happening over a period of time or it happened acutely, we need to check on that. But, great case, and hope the patient is doing well. Thanks.
Abhishek, if you don't mind, I think our Narayan Nambudri must be around. So maybe we can get some input from him. Narayan, can you just unmute and speak if you're around?
Am I audible?
Yes, Narayan.
I mean, great inputs. We didn't really consider an epicardial ablation at that point. The lead position looked quite scary. We wanted to take the safest approach. Of course, we could have pulled out, but we didn't want to have another complication who already had a problem. That was the reason. And it was done outside by a relatively senior cardiologist, not by an electrophysiologist. And he recognized it quite early when the patient had it. And he wanted to have a safe approach to the patient. That's why we opted for a surgical one rather than pulling it out. Thanks for the inputs.
And Narayan, I have a question. You see, this noise protection, if you go through those traces, you have had those VS2, and that means it is considered as a noise, and there were some ventricular pacing. That is, I think, sometimes could be dangerous. That could also cause, arrhythmias. You agree with me?
Yes, absolutely.
So that's a double-edged sword, that protective mechanism.
Yeah.
So thank you. I think we ended in time. The first set of the presentation, Dr. Suresh, Nituja, Ushnish, I think a great beginning. It was a lot of learning. And the first set of moderators, Abhishek, thank you so very much. You always, support us. And, I wish, you're always with us. Saxena ji, namaste, and thank you very, very much. Ajit, as usual, your inputs were great, especially your analysis of the 3D mapping. I think we are waiting for that newer version of the Insight, so we will also be a little more knowledgeable about that. So thank you, Ajit, everyone. The first set of presenters. Let's go to the next set of presentations. And we have Krishna Kumar Mohan Nair, now migrated to Kuwait, emptying the EP space in the country. We miss Krishna. Welcome. Dr. Nitish Bhadar, who is our great friend, who is the director of cardiac electrophysiology training program at the Stanford University School of Medicine. He had been of immense help to the EP program in our institute for the last 2 decades. He's consistently helping us out. Nitish, if you're around, say hello to us, please, Nitish. So, and then to replace Raja Selvaraja, who is busy, we have Chenni Sriram, a very learned and accomplished electrophysiologist from the pediatric electrophysiology department from Detroit, who incidentally is in India. So, Krishna and Chenni, welcome. Is Nitish around?
Thank you.
All right. So let's begin with Dr. Malavan Muhammad Ali. He's from Dr. Yash Lokhandwala's unit. He must be very, very proud and fortunate to have the guidance from none other than the master of the masters of electrophysiology in the country, and that is Dr. Yash. And I think Dr. Yash is online, and we can always learn something more apart from what Dr. Malavan is going to be presenting. So, Dr. Malavan, welcome. Start your presentation.
Yes, sir. Thank you. Just I want to share my presentation. Sorry.
So, Malavan, you are from India?
No, I am basically from Iraq.
Oh, I see.
I'm from the northern part of Iraq, from Kurdistan. But I cannot share my presentation. Sorry.
Okay. So wait, I think our team will help you.
Can they share my?
Sangeeta, I think take care of this.
Yes, sir.
So, can they allow me to share? No, we have did some changes on this actually.
Sir, you can share your presentation, sir.
Sangeeta, you'll have to mute, the background noise. So, Malavan, is it okay now? Can you share? Yes, I think it's coming up.
Yes, ma'am. Really, I cannot. It's appear no, sir. Sorry.
So, Sangeeta, will you please guide him? Dr. Malavan, can you press on the share screen? That's the green one in the middle.
Yes, I am pressing then.
Oh, I see. Yeah. All right. So maybe you would log out and come in. Sometimes that helps. Sangeeta, you had given him the rights to share the screen?
Yes, sir. I've already given the rights to share him, sir, the screen. And he's already sharing the screen, sir.
Oh, this is his screen.
Yes,
Yeah, okay. So you'll have to put up your presentation, please. You'll have to go to the new tab.
Yeah.
So your screen is visible, sir. You can share your presentation, sir.
I don't know why it's not coming.
Oh, I see. All right. See, may I request Malavan to hang around? You can log out and please do join in. Sorry for that. Shall we move to the next presentation? May I invite Dr. Sai Kiran Kakrala now? Again, the resident from Sri Chitra, the prestigious institute, Sri Chitra Tirunal Institute of Medical Sciences.
It is visible now?
Oh, yes. Perfect. Okay.
Okay.
All right. Yeah.
Okay. Thank you for inviting me to this very wonderful event, and thank you for Seriash for having me as an EPO fellow from Kurdistan, northern part of Iraq. So today I will present a case under the title of fallacy of spot diagnosis of SVT. Here is our patient is a 39-year-old man. He had recurrent episode of a rapid palpitation since 2019. He had been admitted twice to the emergency room for tachycardia, which was terminated by intravenous verapamil. He had been diagnosed as a case of supraventricular tachycardia in the form of AVNRT. He underwent EP study in 2020 in the Netherlands with unsuccessful attempt at slow pathway ablation. Is my sound clear, sir?
Your slides are seen. You are very well heard, Dr. Malavan.
Okay, thank you. Okay, so as per the report which provide to the patient, an attempt to interrupt the tachycardia were only successful for very short time. A modification of slow pathway result in a very few junctional beats, and energy during tachycardia result in intermittent VA block without affecting the tachycardia. In view of proximity to the AV node, the procedure was aborted, and patient kept on medical treatment with verapamil and beta blockers. Now, 4 months back, he underwent another EP study for the second time in India, and during catheter placement, he got sustained but self-limiting tachycardia at a rate of 130 beats per minute was seen during the study. But then after no tachycardia were inducible, providing the patient have taken 120 milligram verapamil on the day of surgery, despite they informed him that no drug to be taken at the day of surgery or before. He continued to have increasing episodes of palpitation, often with admission to the emergency room. Now, during the ECG during sinus rhythm, there is nothing significant apart. There is mild prolongation of the PR interval at 220 milliseconds, basically narrow QRS complex and normal access. However, during tachycardia, the clinical ECG shows again relatively narrow QRS complex at 100 milliseconds with left axis deviation. There is short RP tachycardia. It is regular with occasionally with only 2 cycle length prolonged, and there is R prime in V1, if you notice here. This is the clinical ECG of tachycardia, and as the patient has continued to suffer from recurrence of tachycardia, we decide to repeat the EP study in Holy Family, and the basal intervals were normal. Non-sustained tachycardia was induced with rapid atrial pacing and atrial extrastimulus, and the tachycardia became sustained with isoprenaline. Initially, there was 1-to-1 retrograde VA conduction, but soon followed by VA dissociation. Here is the 12 ECG during the tachycardia, same as clinical ECG. As you notice, there is a narrow QRS complex with variable RR interval at a rate of 150 to 170 beats per minute, and there is left axis deviation and RS pattern from V1 to V6. Now, as I mentioned, tachycardia have been induced during atrial pacing, initially with 1-to-1 conduction, and as you notice here, and then there was clear VA dissociation. And here we got a negative HV, which is minus 16 milliseconds, that his potential preceding the QRS complex by 16 milliseconds. Our initial approach actually is to target the earliest potential, and delivering the energy at this area was unsuccessful. The local activation time here, as shown, is almost 0. However, we try to go higher up in the septum and more anterior at the region of left his, and the local activation time at this area shows minus 20 milliseconds. Again, it is shown here, this sharp potential, that is the local potential, which is ahead from the QRS by 20 milliseconds. Delivering energy, here we use the bidirectional catheter for the mapping, and the delivery of RF energy at this site was successful in terminating the tachycardia. Now, here we show the site of the ablation catheter both in RAU and LAU. We are just at the left HIST area and adjacent to the HIST and adjacent to the left bundle area. If you see here as shown. Now, the delivering energy was at this position was successful in terminating the tachycardia. Now, no tachycardia inducible after this, despite isoprenaline and program stimulation. 6 was follow-up. There was no recurrence. So we suggest that this is a case of upper septal VT. And this kind of VT actually have first been recognized by Taleb and his colleague Nogami, and they published a paper in which they study around 12 cases who have upper septal VT, and they show the prevalence mechanism and physiological characteristic of this type, a rare type of idiopathic left ventricular tachycardia. They postulated that the mechanism of this type of tachycardia is just the reverse of common idiopathic left ventricular tachycardia. Thus, the common idiopathic left ventricular tachycardia use the left posterior fascicle, which is labeled as P2, as a retrograde limb for the reentrant circuit, and the antegrade is labeled as P1. And this is shown here in the intracardiac electrogram that during the ventricular tachycardia in upper septal VT, that it is just the reverse form of the common idiopathic ventricular tachycardia. However, more recent studies have been published by Migi et al. And have been presented in Europace in 2023. They proposed that this type of, or to eliminate this type of tachycardia, actually the target should be at the early potential, that is the local potential, without having P1. So the antegrade direction also is just the same as the common. There is no retrograde, or the P1 was not there. If you notice here at the left posterior fascicle during mapping, there is no P1 potential. And actually, it is wise to mention that during such a form of tachycardia, it's always to look for the HV timing. Now, in both the mentioned study, that the HV timing during the tachycardia was shorter than that during the sinus tachycardia. Although in the second study, as I mentioned, by Migi et al., the HV interval was a bit longer in comparison to the first study. The second study include 18 cases. However, having a pseudo-normal form of HV interval in case of upper septal VT have been also published by Vijay and Sir Yash Lokhandwala, in which they found that in upper septal VT, you may have even pseudo-normal HV interval. In summary, upper septal verapamil-assisted idiopathic left ventricular tachycardia is a rare variant that may be mistaken for supraventricular tachycardia, and more common in men. It is more common in men, actually younger men, and it is verapamil sensitive, and basically there is no structural heart disease. Damage to the left posterior fascicles of the Purkinje system may be responsible for the development of this arrhythmia, since 50% in the first study, 50% of cases they have previous history of ablation of the posterior fascicular VT. That is the common variant. Eliminating this ventricular tachycardia require ablation at the earliest Purkinje potential site, which is close to or overlap with the left side His, and catheter ablation should be performed cautiously in this region to avoid damage to the conduction system. And thank you.
Thank you, Dr. Malavan. So I invite Chenni Krishna Kumar, if you are around, to lead the discussion. I hope Nitish has joined. Nitish, around? All right, so Chenni and Krishna, please.
Thank you, Dr. Malavan. It's a wonderful presentation. Is it okay if I go, or somebody else wants to start?
No, I think Chenni, you take over first.
So I think that this is a wonderful case where you can easily mistake an SVT, you can easily mistake a verapamil sensitive vesicular VT for an SVT. I think thing that I would emphasize, as you had emphasized here, is the negative or the shorter HV interval during, it doesn't have to be negative, it can even be shorter than the AVNRT HV interval. So that's the first point. And oftentimes we do see this kind of tachycardia being induced with atrial extra stimulus for obvious reasons. You can have a reentrant tachycardia coming from the fascicles that can be induced by an atrial extra stimulus, as I've shown here. So those are the 2 points. And it doesn't have to be a negative HV interval, as I said. It can be, the HV interval is dependent upon the time it takes from the turnaround point to get to the His. The His will obviously be a retrograde His, right? If we have a multipolar catheter at that site, you can sometimes show that the His that you're seeing is a retrograde His rather than an antegrade His. And that is a point that sometimes you can pick up, but oftentimes that is not picked up. But showing that HV interval shorter than the tachycardia HV interval is a good starting point. So yeah, anybody else wants to go ahead?
Krishna Kumar, are you around?
Yes, I'm around, sir, actually.
Please, welcome.
Yeah. So yeah, thank you, sir. Thank you for the opportunity. So this is an excellent case from Professor Yash Lab, and it was an excellent presentation. So so this is a case of like a narrow complex tachycardia with AV dissociation. So when we deal about narrow complex tachycardia with AV dissociation, there are only few differentials. One is an AVNRT with a retrograde nodoatrial block, or a junctional tachycardia with a nodoatrial block, or an orthotomic nodovascular, or a nodoventricular reentry, or an upper septal VT. So the first 3 differentials usually they have a positive HV interval, and usually the upper septal VT, here H is actually a bystander. So getting a negative HV interval was actually very convincing in this case, and you should appreciate the EP team there to be able to tag this His as well as identify the HV, so that the diagnosis was made convincingly positive, and also to map the earliest Purkinje potential without any 3D system. It's also very to be appreciated, actually. So I think it's a very interesting case, as well as a lot of points to be learned in all aspects. Thank you.
If I would like to make a comment, see, the morphology was a little unusual for the
superior axis.
The axis was like, it was like incomplete right bundle. If you see the tachycardia ECG, it was like an incomplete right bundle. But if you can also see that's a deep and V6, and there is a left axis actually.
Yes.
So yeah,
Yash is around. He can speak about the morphology part of this.
Yeah, Ullas, can you hear me?
Yeah, absolutely, very clear.
So what I would like to make 2 points, especially for the people budding electrophysiologists and the fellows, is that there is this hurry that you see A on V tachycardia and you jump to AVNRT. But here sometimes it even happens with experienced centers. But here people are A on V, and then they say what maneuvers to do. And the first thing is to look at the HV. And then they think we don't see the His, okay, the His bundle catheter has moved, so ignore it and let's go for. And in fact, both our upper septal VT patients had, even the previous one, which were twice ablated for AVNRT. And this is happening not only in India, but I was surprised that it happened also in Europe. So it's probably, some lesson to take that, look at a good His bundle signal first in AVNRT, at least rule that out of the way. And of course, nodovesicular, nodoventricular are very difficult diagnosis, but at least we should not fall into the trap. Now, second thing I wanted to what we did not do here is prove re-entry. We ideally should have done the entrainment and shown that it's re-entry, but this was the third procedure for this patient. Already once tachycardia had become non-inducible. So I said that at least let us cure this patient and, cut short the procedure, because the diagnosis was pretty obvious. Now, the mechanism, whether it was a re-entry or not, I think probably would have made a little difference, but not much difference to the ablation mapping, to the mapping procedure. Actually, we stopped the energy and we continued the energy in sinus rhythm, and he got AIVR. So we did atrial pacing to eliminate the AIVR and give energy, because you have to be definite that you do not damage the AV conduction system.
What are your comments about the morphology of it?
See, here, as someone rightly said, if you look carefully, also the R prime, when there's 1-to-1 VA conduction, you get the R prime, and when there is no 1-to-1 conduction, you hardly get any R prime. So it's not really an incomplete right bundle. It's more like maybe a slight R prime was there, but most of the time the exaggerated R prime was because of the P wave. But the left axis should certainly alert one. And one can even pace the atrium faster and see that you don't get this type of left axis.
Perfect.
And also, if you look at the V6, there is a prominent S wave in V6 actually. So without getting a right bundle morphology in V1, even if you get a deep in V6, then that's also quite unusual for a supraventricular tachycardia.
See, if you look at this ECG, when the VA conduction is lost in some beats, the R prime is gone in V1. If you look in the center of the tracing.
Yeah. Yes. So, Chenny, final comments, please.
No, wonderful. Again, as I said, it's a wonderful case. Always, as Dr. Yash Lokhandwala has already proven how to analyze the electrograms, and the point is well taken. Always get a good His, get a multipolar catheter at the His level. Make sure if it's an antegrade His or a retrograde His, carefully look at the HV interval during tachycardia and HV interval during sinus. Obviously, if you have HV interval less than the sinus, that's another point in favor of a vesicular VT. It doesn't have to be a negative one, as I said. It has to be a shorter HV interval, and the HV interval depends upon the turnaround point. Where from the turnaround point, the time you take to the His, the more superior the turnaround point, the shorter the HV interval can even be negative. So, depending on all those things. I think the other thing that I want to ask Dr. Yash Lokhandwala is the posterior fascicle in the left posterior fascicle always the retrograde limb, or is it just more like a bystander, or is it just now there are some nuanced interpretation of the circuits where they say that the left posterior fascicle could be antegrade limb, and then depending on how that the slow zone connects, it can connect perpendicular or parallel, and based on those nuances, you may or may not get that pre-potential, like the P1 potential.
Yes, absolutely. I think people had implicated the false tendon, but even in patients as one of the limbs, but even in the absence of a false tendon, most hearts do not have a false tendon, and yet you get where you get this type of VT. So you're right, the retrograde limb is variable. It need not only be the posterior fascicle.
All right, so thank you, Chenny, thank you. And the audience who have joined in late, let me reintroduce Chenny Sriram, who had been great support to our EP program. Chenny Sriram is a famous electrophysiologist in the US. He is a consultant at the Children's Hospital of Michigan and Detroit Medical Center. And currently he's in Chennai. So Chenny, thank you so very much.
Thank
So
you so
let's
much.
go to another presentation now. It is Sai Kiran Kakrala from Narayan Nambudiri's unit from Sri Chitra, the prestigious institute. Welcome, Sai Kiran.
Good evening, everyone. I'm presenting. Thank you for the opportunity. I'm presenting a case of a radiofrequency ablation in 11 kg toddler. So here is our index case. Child is 1 year 10 months, who is a diagnosed case of severe Epstein's anomaly of tricuspid valve with a small bidirectionally shunting atrial septal defect. Had good LV function with a severe RV dysfunction. She got a poor functional RV and WPW syndrome with right side axillary pathway. She had multiple episodes of incessant hemodynamically unstable narrow complex tachycardia, which required cardioversion and admission. Currently, she is on oral medications on beta blockers and amiodarone. Her weight is 11 kg, saturating around 95%. She was planned for a cone repair. Prior to the cone repair, she was referred for the ablation. So this is the office ECG, which is showing normal PR interval with a normally appearing QRS complex, where you can see there is absence of terminal R wave in lead V1 and the subtle pre-excitation. This is not fully pre-excited, subtle pre-excitation, where you can see the delta wave is isoelectric in V1 and it is positive in lead V2, and early precardial transition, likely negative in AVF and isoelectric in lead 2. Overall suggestive of right-sided posterior near septal axillary, postoseptal axillary pathway. This is the echo of the same child, which is showing apically displaced tricuspid annulus with a severe TR and a poor functional RV with a severe RV dysfunction. So the child is planned for the cone repair. Prior to the cone repair, it was recommended to have an EP study if the child is symptomatic. A recommendation comes as class 1 as per the recent ESC grown-up congenital heart disease guidelines. So the child was taken up for the ablation. So since the child is only 11 kgs, we have limitation in the getting access and other issues. So we have taken 2 access. One is from the right internal jugular vein with a 6 French radial slender, and one from the right femoral vein, 8 French short sheath we have taken. And we use 2 catheters. One is deflectable quadripolar from the jugular axis, and we use standard 4 mm tip non-irrigated ablation catheter from the femoral root. So during procedure, this was the initial ECG, which recorded sinus rhythm with prominent P waves and RSR pattern in lead V1, suggestive there is no pre-excitation with a splintered QRS in the precordial leads. So we went ahead with the protocols, ventricular burst pacing with his catheter with a quadripolar catheter marked as a his within the RV, and ablation catheter at the annulus, which showed ventricular burst pacing showed VA conduction, concentric VA conduction at 460 milliseconds. So during catheter manipulation, spontaneously tachycardia got induced, which is wide complex tachycardia. As you see, there is no subtle change in increase in the right bundle branch block morphology is there during tachycardia, and it is wide complex tachycardia. And all the tachycardias which were inducing were very hemodynamically unstable. The child is the systolic blood pressure of the child during tachycardia was around 30 to 20, which needed immediate cardioversion and desaturating also. So in that prior to cardioversion, we strategically we have put 2 catheters, one the quadripolar catheter near the posteromedial location, and the other catheter into the RV near around 6 o'clock to get the maximum information. So then after cardio, this is the zoomed up view of the tachycardia. We can see narrow complex, wide complex tachycardia with RBBB morphology in the cycle length of 290 milliseconds, where you can see the ablation catheter at the 6 o'clock position of the tricuspid annulus, and the quadripolar catheter near the posteromedial location. You can see there is the VA appears to be constant, and there is a the VA interval is slightly narrower in case of quadripolar catheter when compared to the ablation catheter. So we thought because of hemodynamically unstable nature of the tachycardia, we went ahead with mapping of the catheter during mapping of the mapping for ablation. So during pre-excitation, during catheter manipulation, suddenly we noted the pre-excitation suddenly increased. As you see here in the surface ECG, where the initial RBBB is there, after during catheter manipulation, this pre-excitation is increased suddenly. When we reviewed the EGMs, it was showing like there is a probably his junctional Hessian, probably that quadrupolar catheter has bumped into the compact AV node or Hessian region, which causes this ectopic. And then after that, because of complete or block, the sole AV conduction was going through the pathway. Because of this, the pre-excitation got increased. So we the maximum pre-excitation morphology, which we saw when we see this is like isoelectric in V1, and there is a early transition in precordial leads with a negative in 2-3 AVF, suggestive of right posteroseptal axillary pathway. This was transient phenomenon, and there was a spontaneous recovery of the AV nodal conduction was noted. After that, we went ahead with atrial protocols. Atrial for the nodal recovery, for the nodal refractory period, you can see here AV nodal at 400-350 of extra atrial stimulus. There is a mixed conduction was there, and at 340 S2, there is a predominant axillary pathway conduction, suggesting nodal ERP of AV nodal ERP is 350 milliseconds, which suggests probably after bumping it is partially recovered. And then axillary pathway refractory period is 310 milliseconds. Then we went ahead with mapping and continued further mapping, where at 5 o'clock position, you can see the ablation distal was showing A and B, but there is no fusion. We chosen to map during sinus rhythm because of the unstable nature of even minimal ventricular pacing. Also, child has this incessant nature of tachycardia. So we went ahead in mapping during sinus rhythm. Sinus rhythm, we mapped for the earliest onset of V, where there is no fusion at 5 o'clock position of the tricuspid annulus. At 6 o'clock, there was no local AV fusion. And at 7 o'clock, there was a good AV fusion with a probable pathway potential. At this place, we have given with a standard non-irrigated catheter, we have given radio frequency ablation. Within 2 seconds, there is a local VA separation, local AV separation was noted. And the ablation was continued for in pulses for 60 seconds, and then the consolidation was given for 30 seconds. Post radio frequency ablation, we have given adenosine to see for any evidence of the residual pre-excitation, which showed there is no axillary pathway conduction. And also there was VA dissociation noted at 350 milliseconds. No tachycardia was inducible on ventricular pacing. AV Venki was noted at 300 milliseconds of the 300 milliseconds during atrial burst pacing. So this was the final ECG, which is showing a prominent terminal R wave in lead V1 and with memory T waves. So this is a case of Epstein's anomaly with severe TR with poor functional RV with manifest right posterolateral axillary pathway with hemodynamically incessant unstable orthodromic AVRT, which was successfully ablated at 7 o'clock position of the tricuspid annulus. So when we review the literature, all Epstein's anomaly, irrespective of the symptoms, those who are planned for the cone repair should be planned to undergo a catheter ablation, catheter EP study at least to see any axillary pathway, any tachycardia inducibility, which was shown in this heart rhythm in this study, which was published in Heart Rhythm. Almost counting near 50% of the patients who doesn't have any suspected arrhythmias preoperatively had inducible different sorts of arrhythmia during prior to the cone repair or prior to the definitive repair. When we see the axillary pathway location, the Epstein's anomaly, most common site of the axillary pathway location is the right posteroseptal area, then followed by the posterior and posterolateral areas. So why is the point important to do ablation or EP study prior to the cone repair or definitive repair in case of particularly Epstein's anomaly? Because in Epstein's anomaly, there is a apical displacement and there is a absence of the delamination of the tricuspid leaflets, which was further mobilized after the cone repair. You can see there is the valve leaflets. The annulus was mobilized from here to here, and also there will be tricuspid annular will be made smaller by multiple sutures. So thereby Further, it is difficult to perform ablation, localizing the axillary pathways also because of the distortion of the anatomy. So to conclude, prior to cone repair, EP study and ablation should be the standard practice. It should not be age should not be a precluding factor to avoid EP study or ablation in those Epstein subset. And the two catheter approach ablation, which we have demonstrated here, is a safer ablation strategy in extremely small channel with hemodynamical instability. Thank you.
Thank you, Sai Kiran. I think it was a great presentation. I welcome Dr. Nitish Badwar. I already introduced Nitish Badwar to the audience, those who have logged in a little late. Let me again reintroduce. Nitish Badwar is a great friend of our EP department for the last 2 decades. Consistently, he is supporting our program, and indeed, he is a very popular faculty during many of our National Indian Heart Rhythm Society conferences. He takes classes regularly. Nitish, thank you very much for being around. We missed you a little while ago when the Dr. Malavan was presenting, and then they again raised the issue of the nodovascular. I just was thinking you should have been there. But anyway, so you take over now, and then you will be aided by Chenni and Krishna Kumar, who are your co-moderators. Welcome, Nitish.
Okay. Thanks, Ulas. I'm sorry, I think I got the times mixed up. I was told like 7:20.
I know we are, surprisingly, the presenters are adhering to the time, and the discussions went on very smooth without much of a hitch. Yeah, maybe we are going a little faster. So go ahead, take over, and then teach us.
Yeah.
We have enough time, Nitish.
Yeah, I think this is a very good presentation. I joined a little bit late, so I don't know if you, but I really appreciated the data that you were showing in the end, where it's important to do before before doing the surgical repair. I think, I don't know if you made the point earlier, but if you show the initial ECG on your presentation, yeah, I just wanted to, I think maybe you made the point, but anybody with Epstein's anomaly who doesn't have a right bundle branch block, I think by default has an accessory pathway, right? So you don't have a right bundle branch block here. So that proves that you have an accessory pathway. I think otherwise, I don't do cases in pediatric patients, but looks like you don't have space to put in catheters. So I think just knowing the anatomy is important, like you showed, where the location of the pathways is. I don't know if the other moderators have any other points about this.
Chenni is a pediatric electrophysiologist. I think he can make some statements. Sheena?
So kudos for taking care of this kid, only 11 years old, toddler, 11 kilo-old toddler, correct?
Yes.
Yes.
10 months, 1 year, 10 months.
Only 10 months. Many EP laboratories would not even touch this toddler. They might just opt for intraoperative mapping and things like that. But I think in selected cases, in cases where you have established or clear-cut evidence of accessory pathway and history of SVP, although the recommendation is to say that in more than 15 kilos or 20 kilos, you can safely do it. There can be exceptions like this where we can perform cases safely as long as the operator knows what they're doing. I think trying to be a minimalist here is probably the best way to do things. That's why the operators have used 2 catheters. Two catheters here makes sense. You don't need a coronary sinus catheter in everybody. Again, you can use 2, maybe 3 catheters. There are 4 French catheters, 5 French catheters. Sometimes you can, instead of using 2 catheters, you can use 3, but the less the better. So it makes sense to be a minimalist in these situations. A couple of questions that I wanted to ask about this case. What power settings did they use? Knowing that, the Epstein's anomaly, the ventricular wall may be thinned out in that region of the annulus. Obviously, we're dealing with a toddler. So what power settings were used, and that'd be sort of informative for us. And was this irrigated catheter or non-irrigated catheter?
It was non-irrigated catheter, sir. We used power settings of 25 watts and then temperature of 30, sir.
Temperature of 30. Okay, that's what you use. What were the actual values that you were getting? I mean, that is the one that you used. Were you actually getting 20-25 watts? Were able to deliver 20-25 watts of power?
Yes, sir. Around 20 to 25, we are able to deliver consistently.
Okay. And the temperature you were not able to, and temperature cutoff was 30 degrees, you said?
Yes, sir.
So, when you have a lot of, I think the point to be made here is that although you use a non-irrigated catheter, if you're delivering 20-25 watts consistently power and you're not exceeding 30 degrees of temperature, probably that non-irrigated catheter is behaving like an irrigated catheter because you're at the valve annulus and there is a lot of PR which kind of cools the catheter. So, you don't, despite using a non-irrigated catheter, the fact that you're able to achieve that kind of power with low temperatures means that it was behaving like an irrigated catheter because of that significant TR or being at the annulus causes the catheter to be well, flushed with blood. So that's a point to be taken. Did you agree with that statement?
Yes, sir. Because of severe TR, it must be happening.
Yeah, because usually with the non-irrigated catheter, the power, if you're not ablating at a non-annular location, your powers, your temperature might go up more substantially. But in this case, it seems like you're able to deliver the power within the cutoff temperature. So that's good. So then the other point is that when you said the patient was hemodynamically unstable, that's why you could not map during SVT, correct?
Yes, sir. Child was having BP of around 20 to 30 systolic BP during tachycardia, which was rapidly sinking during tachycardia. So that's why we could not map during.
Pediatric electrophysiologist, I do deal with Epstein's anatomy a lot. Usually, the reason why you have these accessory pathways in those locations has to do with the fact that the pathophysiology behind the Epstein's. The valve, it's a failure of delamination. Normally, there is a delamination process where the valve leaflets get separated from the ventricular myocardium. And if there is a failure or arrest in the delamination process, then the valve leaflets that are usually the valve leaflets that are most affected is the septal followed by the posterior and then the anterior. Therefore, there is disruption of the annulus at the level, and that's the basis of the accessory pathway. So these accessory pathways usually follow the leaflets that are most affected by the failure of delamination process. So usually it's going to be in the posterior septal area. Usually, it's very less likely to be in the anterior area, but I guess it can happen. In most cases of Epstein's, it's the septal leaflet that is most affected, followed by the posterior leaflet, and the anterior leaflet is more like sail-like, and it's often used for the repair. So yeah, you expect to find pathways in those locations. So it makes complete sense to look for pathways there. And in this case, you had a maximally pre-excited ECG that told you where to look for it. But even if you don't, I think that's the area to start with.
Yes, sir.
Wonderful case, by the way.
Yeah. So
very
I think Chanik, can you see some of the questions in the chat box?
Where is that?
I'll read it up. Debabrata, our friend from Kolkata, a renowned electrophysiologist in the country. So he's asking, why jugular approach in a kid?
I'll have to ask them. I think I have, when I've done a 15 or 20 kilo kid, we have done one femoral artery, one femoral on one side and another femoral. So it doesn't have to be a jugular, but I think in this case, they just wanted to use Maybe they want to preserve the femoral veins for surgery or something like that. I don't know.
Yes, sir. We thought to use one jugular. We tried to use the deflectable quadripolar to attempt CS cannulation, and so we kept like that. And other femorals we thought surgeons will use for the CPB cannulation, and also we thought we used only jugular and one femoral.
I think it makes sense. I think you can minimize the number of access points, but you can use two femorals if you want, both sides. The catheters that you used was an 8 French ablation catheter?
Standard, yes, sir. Standard 4 mm tipped 8 French ablation catheter, sir.
What
There
French
used
it was? What
There
French?
used to be a 5 French.
Yes. So
Yes, sir. We don't have that 5 French ablation catheter, so we have used the standard live wire ablation catheters.
Okay. The EPT is a 7 French. You can use that too if you're using it as a non-irrigated.
but Jenny, we have 5 French catheters available in the country.
Yeah. So that is something
Right,
that is
so
kind of
great.
usually out. That is not easy to find even in the United States. When I have to do these cases, you ask them. Oftentimes it's out of stock. So end up using the EPT 7 French or the 8 French.
So Krishna Kumar Mohan Nair around.
Yes, sir. Actually, it's
go ahead.
wonderful to see a pediatric case from my Pan Institute and from my teacher, Dr. Nambudiri. So I have a few comments, sir. Actually, so identification of this pre-excitation pattern in Epstein's is very important. Actually, like if there is no right bundle branch morphology, if the PR level is normal in an Epstein, we have to be careful. We are dealing with a pre-excitation because the problem happens means not outside actually, because if we take the patient for a surgery and if we miss it, if we miss the pre-excitation and if the patient goes into tachycardia, then to be like an incessant tachy, and you have to understand that incessant SVT can be lethal, can be detrimental in an Epstein actually. So that's my teaching point number 1 actually. And second thing is tackling these pathways have to be done prior surgery, because after this contrapara and all, there'll be a pseudo annulus, so that if the surgeon is not able to tackle the pathway perioperatively, and then tackling it later will be difficult. So I think these are the 2 things that I want to specify. And also interesting to note that this patient had only 1 pathway. Usually we expect 1 or 2 pathways, and then Mahem also. I still remember Dr. Nambudiri doing one 6-month-old Mahem when I was there as a fellow and a consultant. Anyway, thank you, sir. Thank you for the opportunity.
Wonderful comments. And you know what? We have another brilliant young electrophysiologist who had been trained in Australia, and now he's a faculty at the Safdarjung Hospital. Anunay Gupta, you are around. I will take up your question and ask Chenny to reply. What should be the power setting if you are using a non-irrigated catheter in a child with the WPW? Chenny? Anunay, you are around? Yeah, he may not be around.
So
But
I think what people do is focus too much on the power settings and forget about what you're actually delivering, right? So power setting is whatever you set on the dial. Actually, what you're delivering is what it matters. Because I can tell you cases where people have used a non-irrigated catheter and they've set the power at 50 watts, temperature cutoff at 70 degrees. And and they're actually, when they're actually delivering power in the AV node region, the power is actually 50 watts and the temperature that they're getting is actually 40 watts. When I look at that, I say, okay, you're delivering 50 watts of power and the temperature is only 40 watts. And it looks like you're making great contact, which means that this catheter is behaving like an irrigated catheter. You're delivering too much power for an AVNRT. You don't need 50 watts to be, if you're actually delivering 50 watts and your temperature is 40, you are delivering enough power. You don't need that much power. Maybe in that case, you have to understand that you're getting enough power and maybe dial it down to 30 watts or 25 watts or 35 watts, right? On the other hand, if you set 50 watts temperature cutoff of 70, and then as a non-irrigated catheter, and then you're starting to deliver power, and then within 20 watts you're delivering power and the temperature cutoff goes to 75 and the power drops. That means that you may have to switch to an irrigated catheter because in that case, you're not the non-irrigated catheter is behaving like a non-irrigated catheter. So it really depends upon the understanding the biophysics of ablation. The dial is what you said. You have to look at what you're actually delivering. Okay, for a kid, I would say when you're ablating in these WPW location matters. For example, if you're able to deliver 30 watts at the annulus, it is more than sufficient in many cases. You can certainly deliver up to 40 watts. So if you are using a non-irrigated catheter, if you set 40 watts temperature cutoff of 70 or whatever, but if you're actually delivering those 40-30 watts easily, and your temperature doesn't even go to 70 degrees, you can be happy that you're delivering enough power as long as the catheter contact is good. Okay, it's about the biophysics. The setting is what you dial. It hardly matters. I look at what the actual power is. I look at the impedance drop. If you're delivering 25 to 30 watts of power, if I have good contact, I have a contact force catheter. Contact force catheter is only available if irrigated, but if the non-irrigated, if I'm sure about the contact, delivering 25 watts and all the 25 watts is being delivered and there is a good impedance drop, the temperature is 30, 40, 45 degrees, I don't care much. I know the power is being delivered well, I will continue, right?
Okay, Chani, thank you very much. Anunay, you have anything to add? I think he's muted up. All right, so Nitish, your final comments for this session, please.
No, I think it's a wonderful case, and like you're saying that this is doing this in such a young kid, it's really commendable. And again, knowing the anatomy is important. And I think the take-home message for people is to start from the ECG in a patient with Epstein.
Yeah.
If you have the right bundle, then you think about that and knowing the known locations. And then I think they did a very good job. I think sometimes also through the jugular, you get a much better contact. Yesterday I did a case where I could not get into the CS from below, and you can easily get from the neck. In US, nobody puts CS catheters on the neck. I'm probably one of the two people along with Sunny Jackman who does that. But I think there is a point that sometimes you have valves and things like that come in, but you also get better contact, in the annular area.
I think, Nitish, you agree with me that the Sri Chitra Institute is like a gold standard for EP education in the country. Such fantastic papers they produce, and what science. Narayan Namboothiri is at the helm there, and we're all very fortunate that he shares his experience. He makes his residents to present, and this whole program, I think we have some 6 or 7 of his fellows who are presenting in this summit. So thank you, the team from Sri Chitra. Now we go to the next set of presenters. And I saw Debabrata around. I hope Ashish had joined. Ashish Nabar, he's the cardiac electrophysiologist. He's a colleague of Yash and Amitora. He is mainly at the Jupiter Hospital in India, my great friend. Ashish, are you around? Debabrata Bera, well, he was trained with Dr. Narasimhan, and now he's a busy electrophysiologist in Kolkata. He is working at the NH Rabindranath Tagore International Institute of Cardiac Sciences. Great academician, produces a lot of papers each year. Debabrata, welcome. Dr. Narasimhan, who does not know Dr. Narasimhan, who had been the president of Indian Heart Rhythm Society, who runs the largest EP fellowship program in the country. Every year he churns out some superb fellows, and they're all very successful, spread across the country. Dr. Narasimhan, are you around? Well, Debabrata, say hello to us. We would like to hear from you. Ashish?
Yes, sir, I'm here.
All right, great. Right, Debabrata, thank you very much for joining us. Let's start with Devendra Bisht, again a foreign fellow, who was a senior interventional cardiologist and electrophysiologist from the prestigious Mount Sinai Hospital, New York, USA. He is going to be talking on some arrhythmias post mitral valve replacement. Devendra Bisht, are you around?
Yes, sir, I am around.
Wonderful. Welcome. And it's such a privilege to have your presentation. I am sure we are going to learn lots from you. You can share this.
Actually, yeah. Sir, I have sent my recorded version because I am facing the network issues here.
No problem. Sangeeta.
I'm sharing, sir.
Okay.
And first of all, thank you, Dr. Nas, sir, for giving me this opportunity. So my case is a conventional 3D case, and the case is a post-MDR tachymyopathy in patient who is suffering with rheumatic heart disease. The case is a 48-year-old gentleman who has past medical history of rheumatic heart disease. Prosthetic valve replacement. In the follow-up appointments, patient developed with rapid ventricular response. Initially, he was kept on mu and beta blockers, by which he was rate controlled with few intermittent conversion to sinus rhythm. In few months post-op, there was noticed a decline in injection fraction.
Sangeeta, we don't see the slides.
So now can you able to see the slides, sir?
No, we don't. Sorry for that technical glitch. I think they will sort it out. Yes, Sangeeta did a good job. I think, if you would like to, rerun the video, rerun the audio part of it, it would be great.
Yes, sir. We are doing it.
Very good evening, and first of all, thank you, Dr. Nas, sir, for giving me this opportunity. So my case is a conventional 3D case, and the case is a post-MDR tachymyopathy in patient who is suffering with rheumatic heart disease. So my case is a 48-year-old gentleman who has past medical history of rheumatic heart disease, for which he underwent prosthetic mitral valve replacement. In the follow-up appointments, patient developed atrial flutter with rapid ventricular response. Initially, he was kept on mu and beta blockers, by which he was rate controlled with few intermittent conversion to sinus rhythm. In few months post-op, there was noticed a decline in injection fraction from 60% to 25%, after which he was considered for radiofrequency ablations. So this is a pre-op electrogram of the patient that shows a narrow complex tachycardia, and there was a 2:1 AV relationship. There were positive P waves were perceived in lead V1 to V2 with decreasing amplitude in leads V3 to V6. Additionally, there is a positive P waves in the inferior leads, while lead 1 and AVL AVR exhibit a negative P waves. These P waves suggest a breakthrough from the leftward side and the posterior superior aspect of the left atria. So the procedure was planned and written informed consent was taken. Patient procedure was conducted under local anesthesia with some midazolam sedation required. Vascular access, the right femoral access was taken for mapping and ablation, and left femoral vein access, the RV quadripolar and CL decapolar was placed. Left femoral arterial access was taken for pressure monitoring, and during mapping and ablation in the left atrium, the ACT was kept in more than 350 seconds. Insight was used as a mapping system, and SDGrid was used for mapping. Irrigated ablation catheter flexibility was chosen for ablation. So these are the intracardiac recordings from the CS and RV channels that showed a 2:1 AV tachycardia. And there is a distal to proximal CS activation pattern. The atrial cycle length was 250 milliseconds. And after entraining from the proximal and CS electrodes, the PPI minus TCL was approximately equal from the proximal and distal electrode, that is around 50 and 45 milliseconds. And during ablation, the entrainment from the LA was showed a near perfect entrainment with the PPI minus TCL of approximately 0 milliseconds. This is a voltage map and activation map of the both the atria that shows a diseased left atrial voltage with regions of scarring that potentially resulting from the rheumatic heart disease and surgical scar of the previous surgery. Activation map of both the atria highlight a proof-dependent re-entry circuit that is observed in the left atrium and parallel activation of the right atrium. This is a additional electrograms from the HT grid that confirmed a very diseased atrial voltage that was not very well depicted on the 3D map. And you can see that the HT grid various electrodes show the various fractionated electrogram that was recorded from the roof and from either from the near the superior pulmonary veins, and they are very much fractionations. After the confirming the roof dependent re-entry, then flexibility was chosen for the ablation, and the power setting was 35 watts, 55 degrees, and ablation was delivered based on impedance. Tachycardia was terminated at the end of roof line with gradual prolongation of the tachycardia cycle length before termination. Strategically, the roof line was anchored to the pulmonary veins, the right superior and left superior pulmonary veins, and additional consolidation bonds were delivered by walking on the line and to check for any residual electrograms, any leak, and SOS ablations. This is a sparkle map, and this is a propagation map that showed a roof-dependent re-entry. So post-procedure program atrial stimulation failed to induce any arrhythmia. However, isoproterenol was not used with the fear of limitation. There was two major limitations of the case was that pulmonary was not isolated, logistics limitation, flow sensing catheter and temperature monitoring was not available. That's why I decided not to go ahead with the pulmonary isolation at that time. Secondly, bidirectional valve was not checked because it was a single transeptal puncture and the septum was very thick. It required gradual dilatation with the dilator before delivering the HLE sheath in the LA. So I decided to use only one single transeptal puncture for the procedure. So I don't have two catheters available to check for the bidirectional block. However, the bidirectional block was not checked, but the line was checked for any residual signals or any other electrogram that was left. Patient was discharged on antiarrhythmic and formalin anticoagulation. LV improved to normal after 1 month of follow-up, and patient is doing well on antiarrhythmic about 6 months of follow-up. So this is a follow-up echocardiogram that confirmed that showed that the LV has almost normalized to normal from the initial 25% before the procedure. The take-home points are the existing literature, however, does not strongly recommend the RFA as a primary treatment modality due to modest success rate and high recurrence rate. But despite this consideration, the potential benefits of RFA cannot be disregarded, particularly in patients who have failed to achieve rhythm control through pharmacological means. And further research is needed to establish the long-term efficacy and recurrence rate of radiofrequency ablation in a larger RSD patient population. Thank you for the patient listening.
Thank you, Devendra. So, Debabrata, you can lead the discussion, and you will be accompanied by Nitish Badwar. I had requested him to stay back. If Narsimhan or Ashish Nabar, if they have joined in, let me know.
I think Dr. Nabar has joined. Yeah.
Who? Dr. Who? Ashish.
Dr. Nabar has joined, I think. Yeah.
Wonderful. Ashish, welcome. So it's actually your program, Ashish. Thank you for joining. So Debabrata, you can start off, and you will be accompanied by Ashish and Nitish as well.
I have a couple of comments. Maybe Dr. Bhadwar, if we can have his comments first, then we can have my doubts. This, sir.
Yeah, no, go ahead.
Okay, sir. Okay, sir. So nice presentation. Just a couple of things. One is, as you showed in the end of the presentation, that is a roof-dependent flutter. generally in roof dependent flutter in the coronary sinus activation looks like something like a lined up, but in your case it was like distal to proximal. This is one thing I would like to know why you expect sometimes it is a distal to proximal activation. And the 3D map looked like little distorted. Is some part of the ventricle is included in it, or it was not a typical view of what you have shown us? And how many transeptal did you take, if you can elaborate on that? But overall, a nice case.
So the first comment is the how do you decided that it is a distal to proximal CS activation? So am I audible?
Yes, loud and
So
clear.
actually, I think it depends on the how much distal your coronary sinus in the CS that will decide the proximal to distal or distal to proximal CS activation. So I'm not sure how much deep my catheter was at that time. But for the 3D case, because we take CS as a reference, so I used to place my CS as distal as possible during mapping. But I'm not sure how much deep my CS was. And secondly, when I entrained from proximal to distal electrodes, so both the entrainments were almost equal. So I infer from these findings that the circuit is breaking from upside down. So it is activating both the CS proximal and electrode simultaneously. And for usually the third question was how much transeptal do you use? So I prefer, if possible, to some transeptal, especially if it is a PVI case, because by one transeptal you can map and from the another you can ablate. But for the flutter case, I used to prefer the single transeptal because I'm not using ICE here in India, which is a usual practice in US.
So, ladies and gentlemen, as I was saying, we got Dr. Narasimhan's presence today. As I was telling, he is the director and the head of the Department of Electrophysiology at the AIG Hospital. His program is the largest of the EP fellowship program in the country. He churns out many electrophysiologists every year. Dr. Narasimhan, welcome, and you please lead the discussion.
Thank you very much, Ulas. Nice presentation again, Devender. One quick question. What was the power setting that you had? Can you go back to that slide?
Sir, it was the 35 watts because it is a irrigated ablation. Sorry.
Can you go to that slide, please?
So actually, it is a recording, sir.
Sir, I'm opening the presentation, sir.
Okay. What is the scar mapping? Was it done in sinus rhythm? There's
No,
one
sir, it
map
was
which showed that the voltages, you were showing one with the scar voltages. Was it sinus rhythm mapping or during pacing? What was it?
No, sir, it was during tachycardia.
Okay. What is the limitation of this?
Yes, sir. Actually, if voltages are better depicted in the sinus rhythm.
Okay. And what is the atrial voltage cutoff for a scar versus border zone?
Sir, I take the cutoff of 0.1 to 0.5 in this case. Millivolt.
No, atrial cutoff has been worked out by Ming Long. The large paper is one from Germany and one is from Ming Long Chen. The atrial cutoff for scar and border zone is different. It's 0.05 to 0.39. And then that comes as, below that comes as scar. And the other one is called as border zone. Anyway, let's just see the voltage map for a second, please. And the power setting, not this.
Before that, yes.
So what is the voltage setting now in purple, and what is there in the roof right in the center? In the roof, you see a low voltage. What is the voltage?
Yes,
can you just bring out the electrograms there, where the late potential, fractionated potential in this low voltage zone?
So it is less than 0.5.
Okay. So this is most likely that is the isthmus for this patient. And secondly, can we go to the next slide, please, in terms of, yeah. So when we use an irrigated tip and when you're in water, I mean, in this irrigated tip catheter and we are doing an ablation, usually the temperature, we don't keep it at 55 degrees.
Okay, sir.
No, you please go back and check. What is recommended is 43 to 44 degrees. Because this is predominantly guided by the power, not by the temperature. And we don't keep a very high temperature because the depth of the lesion will be much higher if you keep it at 55 degrees.
Okay.
So just this is not the setting in terms of safety, because the worst complication that can happen in the left atrium is roof perforating. Surgeon also cannot reach easily. So roof, generally we try to have a parallel ablation instead of perpendicular ablation like what this catheter is coming up. You deflect the catheter and just come along the parallel surface, and contact force, as you rightly mentioned, would have added a lot more safety to this. But good results and congratulations. Nice case.
Thank you, sir. Thank you.
Can I come in here, Ullas?
Ashish, you are the expert in the flutter. I mean, your inputs are very important.
Devendra, great presentation. I just want to, maybe I missed because I was on phone. Was it a focal ablation in the isthmus or was it a linear ablation?
It was a linear ablation, sir.
Right.
I connected
And,
the RSPB.
Yes. Correct. And now, can you tell us something about what were the incisions what were the surgical incisions? Was this an incisional re-entry, or you think it's a rheumatic process-related scar causing a re-entry?
So I discussed with the surgeon, sir, and he told me that he used to give incision in the intraocular septum during mitral valve replacement. So it was my doubt also that whether he give the incision at the roof, but he denied that the incision was at the intraocular septum.
Correct. So I think that's the standard incision. So this is probably a rheumatic scar-related re-entry, you think?
Yes, sir.
And did you induce for any other arrhythmias in this case?
No, sir.
Were any other arrhythmias inducible?
I did a program stimulation, but I haven't used the isoproterenol because my fear was that I may induce atrial fibrillation. So without isoproterenol, I didn't able to induce another arrhythmias.
So clinically, patient had only one tachycardia, which was at least thought to be responsible for tachycardiomyopathy, and you could not induce anything else.
Yes. The patient was on 6 months of follow-up post-surgery, and he has consistently demonstrated one kind of EKG.
And he was on follow-up with any kind of antiarrhythmic drugs or off-wall drugs?
So no, I kept him on MU purposefully because my fear is that I haven't performed the pulmonary vein isolation. So there are chances that patient may develop the recurrences with atrial fibrillation and follow-up.
And do you think that the POA morphology really helps to localize in a re-entry? In a focal, it becomes the exit site and therefore you can. But in a re-entry, do you think it can help you to localize where the circuit is?
To some extent, yes, sir. I think it can help in localization.
In a micro re-entry, maybe, but in a large re-entry circuit, it's going to be a little difficult. Plus, there is influence of the opposite atrium, which is also activated and which can influence the POA morphology.
Yeah, definitely.
Sure.
Yeah, so thank you, Ashish. I have a question to Narasimhan, and Nambudiri must be around still. They probably have some larger experience of rheumatic heart disease flutter ablations. We at our institute in the last, say, 15 years, maybe we have done about 15 to 20. We don't do it often because I believe, there could be a higher recurrence. I would like to know from Narasimhan, and I think Narayanan was about to make some comments here. Narasimhan first. What should be our approach, in case of this resistant, so-called atypical atrial flutters of rheumatic heart disease?
Okay, I'm glad you brought it out because first and foremost, when you have these patients, we have, in fact, it's not one of our fellows wrote it up. Undiagnosed prosthetic valve dysfunction has to be ruled out. Subclinical thrombosis, because unexpected LA pressure elevation leads to flutter. That is the only manifestation of thrombus in the mitral valve that needs to be excluded. Second is in patients, several patients, there'll be 1 or 2 flutters. Once you ablate them, they go on well for about 2 to 3 years, and then they come back with 1 or 2 recurrences. So for refractory flutters, it's still a very useful strategy. And we can maintain them provided there's no progression of valve disease. They do well over a period of time.
Yeah. Nambudri.
Yeah, as Narasimha sir said, generally these happen in the early course of the illness. Most of these cases have a LA dimension of around not more than 50 at least. And the cases we have mapped, we have very high prevalence of roof-dependent flutter. It must be, I'm sure it must be, they are all dual or multi-loop reentrant tachycardia. Common isthmus could be roof. And ablation of the roof, especially if it shows isochronic crowding, had caused in termination of the tachycardia. In a few cases, we had a peripulmonary vein re-entry. And generally, pulmonary vein potentials are sparse in them. We don't think pulmonary vein could be one of the potential sources of reentrant circuit or part of reentrant circuit. But we have only limited experience. Not many. Compiling together would give all this experience would give some better insights.
Yeah. Sure. Yeah. So Nitish, your inputs.
Yeah. So I wanted to answer one point. So can you show the presentation? I wanted to illustrate a point that.
Yes, I'm
I think it was a very good case that you showed in terms of entrainment. You got equal entrainment from both proximal and distal CS. Usually when you get that, you think of mitral annular flutter, but then on the roof, you got a good timing. If you go to the EGM when he was showing the before this, this one. Yeah, I think so. One point I wanted to make for people who are, I think he has a better one before this. Yes, this one. So, even if you don't have, say, the 3D mapping system or a high definition grid catheter like he has, one thing I do is, which you can see here, you just gain up one of the leads, like in V1. Usually V1 is a very good lead. You gain up the P waves, okay? And this is a reentrant flutter, right? So you're looking for the diastolic corridor. So if you gain up the P waves, and then you even if you don't have a mapping system or a high definition thing, you can just take in a ablator, and wherever you find signals like this, right? So the entire diastolic corridor is taken up with this catheter. So that tells you that is the site where you're going to have, where the meat of the isthmus is, and that is where you're going to terminate these kind of flutters. So I thought this was a very good illustration. The other thing is, just like you do ILAM in the ventricle, if you have a patient having multiple VTs, so you take them and you look for an ILAM map and look for crowding in sinus rhythm. So the similar work has been done with flutter. One of my fellows, Chris Woods, has published that. And he showed that, in rheumatic heart disease, obviously you can have a scar in other places. And like Nambudri pointed out, looks like roof is a common site. But another common site is anterior to the appendage, the base of the appendage. And one of the reasons for that is that the aorta, pushes on that area. So what, Chris has shown is usually you do an ILAM map, you would pace. So, even though you had a single transeptal, you can still assess block in your line with the grid catheter, right? You can just take it across and you will know if anything is going through because it will pick up small signals. But also you will be able to find other areas of ILAM. And if you find that, then I would probably, do those because those are sites where future flutters can come back.
Thank you.
Yeah, so Debabrata, would you like to say something finally?
No, sir. All good.
Great, sir. So thank you very much, Devendra. Now, it's my pride to present Dr. Anbarasan, my own EP fellow, brilliant at that. He's the National Board of Electrophysiology fellow. He joined this year. He's going to be presenting an unusual ventricular tachycardia. Welcome, Anbarasan. Sangeeta Anbarasan is around?
He's sharing the screen, sir.
Okay, good, good.
Good evening to all of you, respected faculty, esteemed moderators, colleagues, and dear friends. Good evening to all of you. I thank my mentors, Dr. Ullas M. Pandurangi and Dr. Anindya Ghosh, for guiding me through. So here I present an unusual ventricular tachycardia ablated at an unconventional site. So coming to the short introduction, scar-related VT ablation involves localizing the critical isthmuses by
sorry, Anbarasan, go to the slide mode, please.
Sorry. Scar-related VT ablation involves localizing the critical isthmus by overdrive pacing maneuvers and 3D activation mapping. Implantable prosthetic devices have been known to complicate this by covering the potential sites of isthmuses and ablation. We herein present a sentinel report of scar VT ablation with protected isthmus localized over an endothelialized post-MI VSD occluder device. A short clinical history. He was a 62 years old male who had recurrent heart failure admissions secondary to ischemic cardiomyopathy with an ejection fraction of 25%. This time he now presented with incessant palpitations for a duration of 1 week. He had an inferior myocardial infarction 16 years ago, which was complicated by a rupture of basal ventricular septum. This was treated by CABG with grafting of RCA and LAD, along with patch closure of the ventricular septal rupture. 2 years ago, he underwent percutaneous closure of residual VSD patch defect with an Amplatzer post-MI VSD occluder. This was done to ameliorate refractory CHF symptoms despite his guideline-directed medical therapy. And this is his ECG on presentation. This shows a regular monomorphic wide complex tachycardia at a rate of 160 beats per minute. It shows atypical LVB morphology in lead V1 with initial intrinsicoid deflection of more than 60 milliseconds, QRS duration of 150 milliseconds, late precordial transition in V4. The mean frontal QRS axis is 20 degrees, and AV dissociation could not be ruled out given the variable undulating morphology. And coming to this is his basal ECG. This or sinus rhythm ECG with normal PR, it has a complete RBB with QRS duration more than 200 milliseconds, and evidence of old inferior wall MI is still present. And the prominent notching in V2, V3 is suggestive of myocardial fibrosis. So this patient was taken up for an electrophysiological procedure, a mapping and ablation. So this is the sinus rhythm bipolar endocardial voltage maps. The settings was scar was represented by 0.2 to 0.0 to 0.2 millivolts. So this is RV and this is LV. So we see the areas of graying, the gray zone, which represents the scar in the basal part of LV, RV, in the basal part of IVS. And this is the LV endocardial mapping during sinus rhythm, which again shows the extensive endocardial scar in the basal inferior portion, which corresponds to his old inferior wall MI, along with the patch closure and then a prosthetic device in situ over there. And his hemodynamically stable clinical VT was easily and reproducibly inducible with atrial overdrive pacing. So his tachycardia cycle length was 480 milliseconds. and tachycardia was induced. An endocardial activation mapping of the VT was performed with a multipolar HD grid catheter in the right ventricle as well as in the left ventricle. The peak intrinsicoid deflection in V5 was used as the fiducial reference for mapping, and window settings were adjusted to represent 90% of the cycle length, as mentioned here, from minus 263 to 176 milliseconds. Here in the left panel, we see this is the isochronal color crowding is seen in the basal portion of the LV in the endocardial region. These red balls indicate the area of his bundle. The middle panel represents the intracardiac EGMs recorded from the area of isochronal color crowding. This shows fractionated EGMs which cover almost 70% of the tachycardia cycle length. And we also see that they are all fractionated multi-component EGMs. And the right panel shows the orthogonal projections in LAO and RAO of all the catheter positions. So mapping was done in the LV with the HD grid catheter through a retrograde approach from aorta to LV. And in the RV, it was done in an antegrade approach. So here we see the Amplatzer device. And above the HD grid was sitting above the Amplatzer device. And the same things are illustrated in LAO view as well. And coming to the EGMs, the EGMs were recorded from multipolar HD grid catheter from the LV at the site of isochronal color crowding. Here we have marked the tachycardia cycle length. Tachycardia cycle length was 480 milliseconds. And we started pacing from C2D2. C2D2 was chosen because it showed the maximum fractionated EGMs that was adjacent to the area of isochronal color crowding. So pacing stimuli were delivered from C2D2 bipole of multipolar HD grid catheter. And near field capture of the mid diastolic EGMs during VT is seen from the fourth paced beat. Here we see the EGM to QRS, which is marked is 240 milliseconds, and we started pacing from here from C2D2. So as we see, P1, P2, P3 was not captured, and P4, from P4 we can see the tachycardia is pulled in with change of cycle length, and this is further evident in this. So that capture starts from P4 with pulling in of advancing of the tachycardia cycle length from 480 to 430 milliseconds, which was our pacing cycle length. Although there was some distortion of the QRS morphology was seen. And the near field EGM to QRS during VT was also prolonged and identical to the pacing stimulus to the captured QRS. And there was spontaneous termination of VT followed by paced QRS beats. So here we see the stim to QRS is equal to the EGM to QRS, which is equal to 240 milliseconds, and the tachycardia cycle length is 480. So this EGM to QRS is equal to stim to QRS and is equal to 50% of the tachycardia cycle length, which tells that the mapping catheter is at the site of isthmus of the tachycardia of the VT circuit. And interpretation here is that there is a concealed fusion with reset of the reentrant VT while pacing from a protected isthmus. And also, we were able to reinduce the same VT and finally document its termination during subsequent RFAs at the same time. And here we see the VT, the morphology of VT beat and the captured beat, they were almost identical. So these are the pacing spikes. So this again indicates it is a concealed fusion. radio frequency energies were delivered at the point of interest in the area of isochronal color crowding. So this shows the ablation signals, and we are able to see some artifacts on that, which probably indicates the metallic artifacts because of the underlying prosthetic device. And we could also see that while ablation at the site of interest, VT is terminated to sinus rhythm. The left right panel shows the right panel. So we are able to see the ablation catheter sitting on top, the ablation just exactly on top of the Amplatzer post-MI device in a levo view and as well as the RAO view. So the ablation characteristics. So settings was 43 power of 30, and it was an irrigation catheter, Tacticath. Total number of RF lesions were 14. Successful RF lesion was number 8. And these are the settings. Here, biventricular endocardial 3D activation map of VT with ablation catheter at the site of successful ablation. The entire cycle length of VT was accommodated in the basal, LV basal endocardial aspect, and we see the right ventricular activation is passive. So based on all the parameters, this was the proposed VT circuit, and this is the area of isochronal color crowding, which indicates the point of isthmus, and that is where ablations were RF energies were delivered and VT was successfully terminated. So endothelialization of occluded devices used for ASDs typically occurs within 6 months to 2 years. This experience can also be extrapolated to VSD occluded devices as well. The neo-hyperplastic tissue is typically devoid of myocardial cells and is traditionally conceptualized as a non-conducting scar. However, there are reports of myofibroblast cell populations in the non-neo-endothelialized ASD devices, and which can be extrapolated to VSD devices as well. And myofibroblast are an essential component within the myocardial infarct scars. They represent a likely substrate for slow conduction when electrically coupled with surviving myocardial tissues arranged in a zigzag fashion. In this context, a zone of slow conduction responsible for a VT isthmus or the site of ablation on the endocardial aspect of a potentially endothelialized VSD's occluded device is hypothesis generating. Thank you for giving me the opportunity.
Anbarasan, I think you presented well. Let's hear the remarks from Narasimhan.
Congratulations, Anbarasan. It's really very well worked out. I would like to congratulate you for taking the pains of going through the electrograms. Can you just go back to that P1, P2 you had marked? You had done it meticulously. Yes. What happens? Where is the line of, where does it block to terminate the tachycardia?
Sir, it blocks at the exit point, sir. Exit site of the isthmus.
So you are pacing, what is the stim to QRS here?
A stim to QRS is 240 milliseconds, sir.
So that is more than 50% of the tachycardia cycle length, isn't it?
Exactly 50% of cycle length, sir. So tachycardia cycle length is 480, sir.
So between this and the QRS you are blocking, go to the next. I think this is not where it terminates.
Yeah, here it terminates, sir.
Yeah, here it terminates.
Yes, sir.
Okay, nice. Okay, go ahead. No further questions.
Wonderful. I mean, we were really very excited that, there will be a greater discussion, but I think you approved this. Narayan Nambudiri, I think you are also agreeing that this is a hypothesis generating. Go ahead, please make some comments.
No specific comments. Greatly, very good case. Well done. And tracing self-explanatory.
Anbarasan was a little apprehensive, but you people are making it appear that he really presented well. I'm so very proud of him. He works so meticulously. I mean, it's a great fellow to have. I'm proud of him. But let's hope Ashish and I think Nitish is also around. Debabrata, each one of you one comment, please, at least.
So
very simple comments. Actually, I fully concur. I fully concur with Dr. Narasimhan and Narayan that very well done case and very eloquently demonstrated those entrainment techniques, and that should be useful for many attendees. Again, a simple point that when you have a right bundle branch block in the basal ECG and you have a wide QRS tachycardia with left bundle, that is a good sign of it being a monomorphic VT, and there is no differential to it, or no need to look for any dissociation, which was a little difficult as you pointed out. In the biventricular activation map, despite this being a LBBB kind of tachycardia, how come there was no early breakthrough on the RV side? Since it was a LBBB morphology, you would expect a breakthrough on the RV side.
Yes,
Was
sir.
there-
We were looking for it, sir.
Can I
Yes,
chime in?
please.
So, it is like, even if you look at the series published by Josephson and Dr. Mark, so they have shown that you can have the exit may be, the exit may be epicardial on the RV, and therefore you may not see as an early breakthrough on the endocardial aspect.
Okay.
It is quite possible. So, we do know that it makes theoretical sense to have it have an exit on the RV, but it's not always the case, and it's quite possible that the breakthrough may be more epicardial. Therefore, you don't get to map it.
Yeah, and then
Correct.
I
So
think the person had told earlier that it was kind of a very, very atypical left bundle branch block.
So basically what happens is, we have done this for deep intraseptal VTs, when you entrain from the RV, the same VT, the PPI minus TCL, everything may be perfect, but it will be at the exit site. Stim to QRS will be 0 or 10. Whereas on the LV side, it will be very long. So when you ablate on the RV side, the morphology will keep on changing. And from the LV side, you will get it in a fewer burns.
Right.
Okay.
Yeah. No, I can understand the isthmus being on the left side, but it is a little surprising that despite having a LBBB morphology, that you don't see a breakthrough on the RV side of the septum. But as was just explained, maybe it's epicardial, and therefore the endocardial map doesn't pick up. What further with this patient? Obviously, does he get a device? Did you give a device?
Sir, ICD was done, sir. ICD was done, and he is on antiarrhythmics also. Maybe for the next 6 months, we are planning, sir.
Right.
ICD has been already done.
Sure. Thanks.
So, Dr. Narasimhan and Nitish, if you're around, do you think this is one of those unique cases? You have any experience about these VSD devices being the substrate for the VT?
No, we have seen this following DORS procedure. Surgeons used to put a patch in the apical aneurysm. We have had VTs coming after their DORS procedure, where it is around the suture line of where the surgeons have put a Dacron patch. You'll see a dense scar, and around the surgeon's suture line at the apex, you'll find VTs coming from.
Sure.
I haven't had experience with a device, but we have had a couple of patients where following DORS procedure, we have had VTs coming up.
Sure. I think many of us have that kind of an experience. Nitish, 1 or 2 more comments from you?
I think, definitely it is hypothesis generating, and you should look more into that. I don't know if imaging will help you, unless if you don't have an ICD, then you can do imaging to look at that. But I also wanted to, highlight to people who are not using high definition multipolar catheters that, this has made our life so easy. This shows you signals. You got the entire circuit mapped out in that area with that catheter. Point-to-point mapping with a 4 millimeter catheter would not have showed you that kind of stuff. And this biventricular mapping, you're showing the whole thing. So I think it's a very good illustration of a simple VT case, but also I think the fact that you're getting it around that site, I think it's definitely what you're proposing is definitely a good hypothesis.
All right, Anbarsan. So my side also, congratulations to you. You did very well. So let's invite Nayani Makkad, again, Chitra Fellow, Nambudri's Fellow. Nayani Makkad, welcome.
Thank you, sir. I am trying to share my. I hope my screen is visible.
Yes.
So thank you for the opportunity to present, and my thank you to Nambudri sir for guiding me through this. I'm going to be presenting the case of my patient, who's a 43-year-old gentleman who presented to our clinic with recurrent episodes of palpitations for the prior 2 years, associated with easy fatigability on exertion for 1 year and bipedal edema for the same duration. So on echocardiography, this gentleman had apical displacement of the tricuspid valve associated with severe TR. So there was Carpentier class C Epstein's anomaly of the tricuspid valve with a small-sized functional RV and significant RV dysfunction. But his primary complaint remained palpitations. This was his baseline ECG. So this ECG actually showed, this was his first ECG in clinic. So this actually showed normal sinus rhythm with a relatively normal PR interval at this time was around 130. With the notable absence of RBBB, particularly the absence of a late splintered QRS and terminal R prime reflection. And there was some suggestion of pre-excitation as well, with the delta wave noted particularly well in leads V6 and V1. He again came about 2 weeks after first evaluation. So he was planned for an RF ablation, but before we could go ahead with the procedure, he was admitted to our CCU with complaints of palpitations. At this time, he had atrial flutter with a 2:1 AV block. And the QRS has changed completely during atrial flutter. There's a loss of pre-excitation with the right bundle branch block pattern with a splintered QRS and terminal R, as we discussed. And this was, the pathway was not very robustly conducting antegradely. We estimated based on these ECGs that the antegrade refractory period was somewhere between 400 and 600 milliseconds. So the patient was taken up for EPS and subsequent RF ablation for the tachycardia mechanism. This was his baseline lab. So at this time, he actually had right bundle branch block, did not have any evidence of pre-excitation. His PR interval was normal at 140 milliseconds. This was confirmed with intracardiac recordings, which showed a normal HV interval of 42 milliseconds. So incremental atrial pacing pre-excitation was unmasked, and assessing the morphology of the pre-excited delta wave, V1 had a R by S less than 1. The transition was late at V6. All 3 inferior leads were negative, which was consistent with the right-sided posterolateral pathway. Tachycardia was induced on atrial extrastimulus, and this was a regular narrow complex tachycardia with a right bundle branch block morphology. It had a tachycardia cycle length of 550 milliseconds with a very long VA interval of 320. So because of the usually dilated RA, there was a difficulty cannulating the CS, and the decapolar catheter is actually not in the CS, it's along the lateral RA wall with CS12 near the lateral tricuspid annulus. So we see here that the CS12 is the earliest point of atrial activation, with much later atrial activation noted in his catheter. And additionally, that it is actually a relatively slow tachycardia, with tachycardia cycle length of 550, most of which is contributed by a long VA interval, likely secondary to the right bundle branch block. Because of the abnormal tricuspid valve anatomy, 3D mapping was used in this case, and isochronal mapping showed early activation, the earliest ventricular activation during atrial pacing near 6 and 7 o'clock of the tricuspid annulus. This was the ablation signal. So there's not much fragmentation of the ventricular signals as we had expected. And there was in fact good AV fusion noted at the site. This is at 7 o'clock on the tricuspid annulus. This was also the potential that was found to be earliest on 3D mapping. So this was the site chosen for RF energy delivery. And this is the same site noted on 3D mapping. And then with ongoing ablation, there is an abrupt increase. So from the stim to V increases at the local site from 122 milliseconds to 470 milliseconds. This is noted again here, where the AV interval increases rapidly from 156 to 240. Here in the initial paced beats, there manifest pre-excitation, and his potential is not clearly seen, which becomes clearly demarcated on the subsequent beats where pre-excitation is lost. This was the patient's final electrogram with complete RBBV. His PR interval after elimination of pre-excitation was 194 milliseconds. So the Steen's anomaly has statistically been defined to have a long PR, in addition to the P wave changes, a long PR interval that is actually proportionate to the degree of atrialization of the right ventricle. So a patient with more severe Epstein's would be more likely to have a longer PR. The majority of this is actually mediated by intra-atrial conduction delay, which is also the likely cause of the prolonged PR in our patient, but other causes have also been discussed, which I'll come to subsequently. In addition to this, right bundle branch block is nearly universal in adult patients with Epstein's, and the absence of right bundle branch block, particularly the absence of a terminal R wave, which represents delayed activation of the atrialized right ventricle, should be considered as a marker of pre-excitation in patients with Epstein's anomaly, particularly adult patients. Just as an SI, this is from one of the older patients from our institute who had Epstein's anomaly with a Mahim pathway. And this has previously been described by Dr. Lokhandwala's group, which suggests that a completely normal ECG in patients with Epstein's actually suggests Mahim pattern of pre-excitation, which is obviously not present after successful RF ablation of the Mahim pathway. Even with even in other patients with Epstein's that we've seen at our institute, there is prolongation of the AV interval, but perhaps it is not as prolonged as it was seen in our patient. Again, as is with the PR interval, this may be proportionate to the degree of atrial dilatation and the severity of Epstein's. As I tried to demonstrate in this figure, when we look only at the local ablation site or at the map signal, when the pathway is present, the conduction time is only along this line. Whereas when the pathway is gone, it actually has to conduct through the AV node and then through the atrialized right ventricle to reach the local site. And again, the degree of PR prolongation is not just dependent on the intra-atrial conduction delay, but anomalies of the AV node and also anomalies of the right bundle itself have been described in such patients. Thank you.
Thank you, Naini Makkad. Wonderful. So discussion. Debabrata must have left. If he's around, he can begin the discussion. But Narasimhan and Ashish must be around.
Nice presentation, Naini. Ashish.
Yeah, sure. I think, Naini, did I miss the fact that that the clinical orthodromic AVRT was present? Because I thought you didn't say that, or did I miss?
So, clinical orthodromic AVRT had not been documented, but the patient had been noted to have a narrow QRS tachycardia that had terminated with adenosine at a local center.
Okay.
He had documented atrial fibrillation, but that tachycardia we could not induce in the lab, so we didn't go ahead with ablating.
No, that's fine. I mean, it was known that he has a narrow QRS regular tachycardia. The other thing is, why did you not consider ablation for the flutter when that was clearly documented?
So in the lab, despite aggressive stimulation and isofrenone, we could not induce flutter. And probably the pathway as well as the anomaly itself were causes for the flutter. So the patient is planned for cone repair, and the pathway has been ablated. So we hope
I think
it will
more
not
so
recur
because,
subsequently.
yeah, that I was going to ask if he or she is planned for a surgical procedure, then probably it's more so the best time to consider ablating the flutter now to prevent post-operative difficulties in the post-operative phase in the ICU or later. But maybe you're planning to do it sometime sooner. Do you think the site of pacing with all the explanations that you gave, decides how easily you can demonstrate the pre-excitation?
So that would change how easily we can demonstrate. And in our case, actually, like I said, the CS12, which we were using primarily for pacing, was actually along the lateral tricuspid annulus. That was probably why we were able to get maximal pre-excitation so easily. It was actually very close to the point of final ablation.
Right. Overall, nice comments in terms of the reason for the PR interval to be longer in this situation. Good. Thanks.
Chenny, are you around? Chenny? He must have left. So, Dr. Narasimhan, your final comments about this?
Yeah, it's yeah, as Ashish was saying, this kind of a patient, once you have demonstrated a flutter, I would have taken care of the flutter also on the same procedure, because especially if the patient is going to go for surgery. But otherwise, it's a very nice case and a good demonstration of intraatrial delay and how the pattern of conduction affects the local AV interval with a decrement. Nice case.
There's a question in the chat box, the mechanism of the right bundle branch block in Epstein's. Dr. Narasimhan, would you take that question?
Yeah, right bundle is due to several mechanisms. One is its stretch and as well. Naini, do you want to answer the question?
Yes, please. There's a question. Why is this RBBB in Epstein's? What are the causative factors?
Like sir said, it is multifactorial. The actual right bundle is also diseased in patients with Epstein's. But in addition to that, there is myocardial disease, particularly in the atrialized RV. So the terminal R is actually obtained by delayed conduction through the atrialized RV, which presents as the RBBB. But it's not even typical RBBB. There's frequently QRS fragmentation and splintering that is also encountered in such.
So that is the reason why they develop VTs sometimes. These patients can come with ventricular tachycardia also sometimes from that chamber. Diseased RV.
Dr. Yash would like to say something, I believe.
I had asked that question because the reason is, there were some references I had read that the failure of delamination, how it produces pathways, also damages the right bundle because it's the septal leaflet delamination failure, and that's where the right bundle lies. So some patients with Epstein's don't have such big RVs, but yet have a very, like you showed in your case, a very broad R prime, So that's why I was wondering whether it's a combination of both failure of delamination, damaging the right bundle, and of course, ventricular volume overload.
Sir, I believe there are histological studies that show that the right bundle itself is also damaged.
Sir, can I make a comment?
Please, please.
Yeah, we had actually looked into a specific substrate to unravel this hypothesis. This is a patient of Epstein with the Mahe fascicular, atriovesicular pathways. Actually, we looked, we have in 18 cases of Mahe in atriovesicular pathways in Epstein substrate, or about 70 cases, where he had done a detailed EP study. And we had found actually the retrograde conduction happens through the right bundle. It is not through the transeptal left bundle. It is always through the right bundle. Almost all of them had right bundle. We could see at the initiation HM transeptal, then going through the right bundle with a local HV positive. That is generally in left bundle transeptal activation. VH will be definitely negative, at least at the location of the His. So this shows probably the right bundle is still conducting in many of them. And most of the time, this atrialized right ventricle is causing the significant delay, especially in that rounded R dash. What we could see in this case is definitely due to delayed conduction. Here in this particular case, the PR at that is more of an educative case. That is why we put it, and nothing great in this. But the local AV interval increased to something like a 470 milliseconds at the time of ablation. It is a combination of intra-atrial conduction delay, AV node delay, right bundle, and atrialized right ventricle delay that caused such a significant prolongation, almost thinking that something else. And we lost the ventricular signal at that point. That is why we kept this case.
Narayan, just a little question for you.
Yeah.
For example, since we are trying to differentiate between the cause of right bundle as a disease in the right bundle versus the RV myopathy, is it possible to say that when you have pre-excitation, if it is related to the right bundle disease, the pre-excitation might be easily demonstrable when the conduction happens by the pathway, or loss of right bundle pattern can be easily demonstrable when conduction happens by the pathway. Whereas if it's a myopathy, then despite the pre-excitation, the right bundle would take a longer time or faster atrial pacing to disappear.
Yeah, could be. Even the atrialized right ventricle is diseased, and complex fractionated atrial electrogram at the site of ablation makes it all the more difficult most of the time. That hypothesis could be correct. But I think, as Yash sir also mentioned, some delamination is also involved in this. But retrograde conduction happens through the right bundle in many of these things. I don't know whether that suggests antegrade conduction is normal. I mean, it's only related to peripheral delay or delamination of the right bundle. Just need to see that.
So great case, Naini, congratulations. We learned a lot about the conduction through the pathway and across the natural conduction system in Ebstein's. Now let's invite the next set of presenters to begin with Dr. Swasti Kumar, again from Narayan's group. And to moderate that, may I invite Suchit, you must be around. Shomo Bora is there since the word go. Shomo, thank you very much for being around. Vivek Chaturvedi, he was waiting for 9:20 to strike. We are actually ahead of the schedule. So we probably will miss out. He told me that, only he would join by 9:20. But Shomo and Suchit, you can fill in his gap. So Suchit, are you around? Okay, so Swasti, may I request you to start presentation, please? Swasti, can you hear us? You need to unmute yourself.
Is my screen visible?
Not yet. In the meanwhile, Nitisha, you are around, right? So be around to please be around as much as possible because we are ending, with another presentation today. Nitish.
Sure.
Yeah. All right. So Sangi, is there any problem with Swasti's presentation?
Ma'am, can I share the presentation, ma'am?
I'm not able to share my screen.
Ma'am, actually, you're a co-host. You can able to share the presentation, ma'am. Ma'am, if not possible, can I share the presentation for you, ma'am?
Yes, please. How do I share my
No,
presentation?
one second. You know what? Can she log out and log in? Sometimes it works. You want to try that?
No, I think I'd better to share my presentation to the person who just talked.
Ma'am, we already have your presentation, ma'am. Can I share that presentation?
No, actually, it is an edited one. Can I mail it?
No. Do one thing. Why don't you please log out and log in and try? Or you want
actually, it is a problem at my end. I think it's better.
I understand. So would you please mail it, and then
Yes.
our team will present it for you. And then may I invite now another presenter, Swasti?
Yes, you can.
Yeah. So you know what? It's my pride and privilege to invite our ex-fellow, if I can call that, Dr. Anand Pasula, who is now a practicing electrophysiologist at KIMS Hospital. Anand, you are around?
Yes, sir.
Yeah, we miss you, Anand. Every single day we miss you. The care and the energy, what you had shown, we miss that. And it's good to have you back.
Thank you, sir.
Anand.
at the outset, I would like to thank my mentor, Ullas sir, for giving me this opportunity. So this is about an interesting ECG case. So I will go to the case. So
you can share, you share the presentation, please.
Yes, sir. I started sharing, sir. One minute. Yes, sir. Now my slides are visible, sir.
Not yet. Yes, yes, and then slideshow, please.
Yes, sir. Yes, sir.
Yes, all set, all set.
Yeah. I'm going to present a case about the malignant effect of a recreational drug use in young. So myself, Dr. Anand, practicing as a electrophysiologist in KIMS Hospital, Bangalore. So coming to the case presentation, a 21-year-old female engineering student, post her birthday party, she developed vomiting, abdominal pain, dizziness, headache, and generalized weakness. So she went to the nearby physician where she got admitted and treated as acute gastritis. In those records, we could see that the patient vitals were 110 beats per minute, and BP was 100/60 millimeters of mercury. Otherwise, other systemic examinations, even per abdomen, was soft. So lab investigations are not much abnormal. Hemoglobin, creatinine, and potassium. So other lab investigations, LFT, all those things are normal. So on the same day night, she developed chest pain, chest discomfort and palpitations. So physician then he tried to do ECG. So he did that. So ECG showed core ST segment elevation with T-wave inversion, and this is consistent with the Brugada type 1 pattern. So one more ECG was same because the physician repeated it again after half an hour to see any progressive changes. So then he referred her to a nearby cardiac center. So in the nearby cardiac center, the patient there also she complained the same thing. At the same time, she developed drowsiness and irritable. Before they could do anything for her, she collapsed in their ER. So this was another hospital. So there they noted the patient is having a wide complex tachycardia, but ECG was not documented due to emergency. So they gave her multiple shocks, and then CPR initiated. They intubated her, and she was put on ventilator and referred to our center. So patient was on mechanical ventilation. GCS was very poor, and her pulse rate was 138 per minute. And when the time she reached our hospital, her vitals were unstable. BP was not recordable even on double inotropes, and she was already in metabolic acidosis. So these are post cardiac arrest lab investigations where we can see elevated bilirubin, elevated liver enzymes, and elevated creatinine also. So here in our hospital, this was the ECG. More or less, it looks like the same. Maybe the lead patient placement was different in our hospital in a year. So the patient gradually deteriorated, and we lost the patient. This was the terminal ECG about 1 hour before her last breath. So in our hospital, we have done echo where there was no RWMA, good biventricular function, normal walls, and no pericardial effusion or clot or vegetation. So we sent a toxicological screening suspecting some poisoning or abuse. So in her urine toxicological screening, we found that tetrahydrocannabinol was 56 nanograms per millimeter, whereas the normal lab reference value was 3 nanograms per ml, whereas cocaine metabolite was negative. So coming to the discussion, this patient actually she went to the she had a birthday party 1 day prior, and they say she was with her friends, and the next day morning she developed her symptoms where she visited the physician. So from then this was the time of events that had happened. So she retrospectively we came to know that she used to have a marijuana smoking along with her friends. So this is a case of marijuana which intoxication which resulted in Brugada pattern, and earlier few case reports were there where they noted it as a benign outcome, but in our patient the patient developed arrhythmia and she collapsed. So she lost her life. So common cardiac manifestations of marijuana most of the time are dose dependent. That may be a tachycardia. BP response may be variable, sometimes hypotension, orthostatic hypotension, or supine increase in the blood pressure. Brugada pattern can be seen with cocaine, cannabis, heroin, and anesthetic agents like propofol and bupivacaine, and psychotropic agents like amitriptyline, lithium, and other sodium channel blockers. The proposed mechanism for Brugada pattern elicited in the marijuana poisoning was cannabinoid receptors type 1, which are predominant in the heart and CNS. So those are partial blocking, partially voltage gated sodium blocking effects, which can result in increase in intracellular calcium and increase in the risk of VT in these patients. So these are the cardiovascular adverse events in a review article, where case reports were noted that patient can have a Takotsubo cardiomyopathy, acute heart failure, stroke, myopericarditis, and coronary thrombosis, aortic dissection, vasculitis, acute coronary syndrome. Coming to the arrhythmias, patient can have a atrial fibrillation, AV block, ventricular tachycardia, extreme bradycardia, and asystole or cardiac arrest, and ACT changes. So coming to the summary, cannabis usage can result in a Brugada ECG pattern. Earlier case reports of cannabis-induced Brugada ECG pattern had a benign outcomes. In our case, we lost the patient. So physicians and cardiologists should be aware of the marijuana manifestations. Continuous ECG monitoring and proper management of arrhythmia may change the outcome in these patients. So these are the few case reports which I came across the literature when I searched. First, it was the Dakaret et al. Who noted that cannabis intoxication mimicking the Brugada like ST segment abnormalities in 2007. Then subsequently other authors also noted there are only few case reports, less than 10 case reports where they noted that Brugada pattern in marijuana intoxication. Thank you. Thank you, Dr. Bulla sir, for giving me this opportunity to present this rare case.
Anand, as usual, very crisp, very up to the point. Thank you so very much. I think it is going to open up a lot of discussion. Let's start with the Shomo Bhora. Your inputs, please.
Yeah, great case, Anand. Just whenever you think that there is a good LV function and you have that ECG, which shows a Brugada pattern, and the patient is hypotensive, toxin-related issues should be kept in mind, whether it is cannabis or Ayurvedic or anything else under the sun, including alphos, should be considered in mind. So let me ask one question, whether smoked cannabis or marijuana or cocaine IV, when it is taken injectable, has any difference, and what is the effect of taking it with alcohol? So any difference in that?
With alcohol, it potentiates Brugada pattern. Even for the say cannabis or cocaine also. With alcohol, the effect will be more.
Yeah. So in your patient, did you really ask that history, whether that was included or not, and what was different, because she was taking it regularly, and if she's taking it regularly, then what was different this time?
She was recently she started, sir. Actually, her birthday was on July 2nd. So she had prior to that 1 month she used to have that parties frequently, and she used to consume alcohol also along with this marijuana smoking.
Okay. So regarding anything regarding IV or inhaled versions, anything specific?
Inhaled versions, they are having more effect, especially in case of cannabis, sir. Cocaine, I don't know the specifically, sir.
See, the problem I think is the accompanying purity. If it has been mixed with other things like ammonia is there, or other mephedrine or other substances, and it has impurities, they can be actually more lethal. So the injectable sometimes can be more lethal if the impure version is there. Lastly, how do you treat these patients if you know that this is a marijuana or a cocaine poisoning?
Basically, symptomatic treatment, sir, for other manifestations, especially for cardiac, we will try to maintain the pH in the near normal or near the alkaline level. at a higher level, probably 7.45 by giving soda bicarbonate.
Yeah, so basically it acts as a sodium channel blocker, and therefore you need to give a lot of soda bicarb. Sometimes hypertonic saline can be used. Lignocaine can be tried, but it has a double-edged sword. So if you have arrhythmias, lignocaine. So how do you think that the ECG changes? So one is, how does tachycardia occur in such poisoning? Is it because you said that the patient has a normal LV? So what is the mechanism of a VT in these tachy patients?
This may be electrolyte abnormality, coexisting electrolyte abnormality, and sodium channel blocking effect also can be the reason, sir.
Yeah, means one is electrolyte abnormality causing Torsades like, but generally many of them would have a broad complex regular tachycardia. And even you can see that sometimes in flecainide poisoning, that you have a regular broad complex tachycardia, and that is primarily because of slowing of conduction so much in the ventricle itself that it reinitiates the circuit within the ventricle itself and causes a very broad regular tachycardia rather than a Torsades like tachycardia. So if you find that tachycardia along with a broad baseline QRS, think of sodium channel blockage. And if you have bradycardia with such patients, especially if you have a sodium blocker, if the patient is taking and you have bradycardia, it is a very bad prognosis. That signifies significant damage already done.
Yeah. Dr. Narasimhan would like to come in, I believe. Dr. Narasimhan, your comments, please.
Yeah, this is a very important case because whenever you recognize this kind of a pattern due to drug-induced problem, two things is, don't use beta blockers like any other arrhythmia. With cocaine, it will aggravate the vasospasm and you can worsen the situation. So drugs are like high concentration of like hypertonic saline and alkalinization of the pH. Both these things reduce the effect of all sodium channel blockers. So even with when you see the ECG pattern and a patient reports to have consumed something, the go-to drug should be soda bicarb followed by hypertonic saline and cooling the patient. These three things will help. And this is, if you support the patient hemodynamically for just 24 to 48 hours, this patient will have a very good outcome. So this is a very good case to go on ECMO as early as possible if the patient is going downhill. You support the patient for about 48 hours, then things will turn around.
Last.
Sir, please.
Very critical points by Narasimhan. We had one case which we sent for publication, but they wanted the levels which we didn't have. This patient presented with incessant vesicular VT. Now, whether it has also something to do with the, marijuana. Again, it was probably contaminated marijuana, may not have been the pure form, but he presented tachycardiomyopathy, incessant vesicular VT, which mimics a posterior fascicle. So this posterior fascicle, this one called the angry fascicle syndrome also. Friend from Israel, what was his name, who had come for the IHRS?
Bellasan.
Not Bellasan, who came for IHRS.
Sami Viskin.
Sami Viskin. So this posterior fascicle, somehow out of all the fascicles, seems to be more prone to get irritated, of course, apart from idiopathic VT, sometimes by ischemia, by inflammation, or even by these toxins. Then for that, any insight?
Yes, sir. This we also have noted many times. The patient comes with a posterior fascicular like tachycardia and behaves like a sustained triggered activity like pattern. Most often it is almost always due to toxin intake, and Ayurvedic drugs have been implicated. We have seen in a few pediatric patients, often it's associated with some ventricular dysfunction also, suggestive of toxic myocarditis. Am I audible?
Yeah, sure.
Hello? Am I
Yeah,
another
all of your statements. Yeah.
Another point in this case, the Brugada pattern was so consistent and unchanged throughout the clinical course. In Brugada syndrome, even in between VT stop, the Brugada pattern in sinus rhythm remains a little bit dynamic as a response to many biophysical factors. This should give clue to a pathological, a toxic reason underlying for the Brugada pattern.
Nitish, if you are around, I'm sure you also must be having some experience with marijuana.
I personally don't have.
Not necessarily you seeing marijuana cases. Yeah.
But I want to really emphasize what Narasimha was saying earlier. It's a matter of life or death. You can save the life of this patient if you put them on ECMO, give hypertonic saline and sodium bicarbonate. I have seen people with flecainide toxicity die, I think, like what Yash was talking about. And it is very common, for these fascicles. I think Yash was trying to make the point that, anything that slows down, you will notice, many times, even non-ischemic patients, you put them on, they have VT from different places, you put them on amiodarone and all that, and then they'll be present with conduction system VT, which was not their main VT, right? So I think any toxicity that happens, these conduction fascicles, especially the posterior fascicle, the septal, we think the septal fascicle is involved in all of them. They're just ready to take off, and then they just go into VF, and it's very hard. But I think Narasimhan's point is very important. I think those three things are, you really got to pick it up and support the patient with ECMO, take them to the center where you can do that.
Yeah, thank you, Nitish, and congratulations, Anand. We learned so much by your case, and you did that toxicology study very, very well.
Yes, sir.
And I'm sure it is publishable worthy. And good luck to you, and thank you so much for participating.
Thank you, sir. Actually, I'm residing in a district headquarters where we are not having the ECMO, all those advanced facilities. Moreover, the patient reached very late, sir. We hardly have 2 to 3 hours to maintain that patient. And I specifically thankful to Dr. Ullah, sir, because whenever I will find interesting things, I used to say the ECGs. Immediately, he told that the patient is having some drug intoxication. Then I inquired about the history. Then I came to know that cannabis, and moreover, the district where I'm residing, Ongole, this is a where marijuana is very easily available to the young children. She's a engineering student, 21-year-old, which triggered that this is an interesting ECG. So I shared immediately with Dr. Ullah, sir. And whenever I'm having interesting ECGs, I used to share with Ullah, sir. And thanks for giving me the inputs. Thank you so much, sir. And thank you, sir, Nitish, sir, and Narasimhan, sir, for giving me inputs.
You learned a lot of things from Nitish also, man. Anand?
Yes, sir.
Yeah, regular classes with him.
Yeah, plus one more point I wanted to make. As something IHRS should take up, these kind of things should be shown in colleges. These students be exposed to these things. You can die,
Yeah, absolutely. Point well noted, Nitish. Swasti, I would like to know, you must have sent the mail. And Sangi, did you get them?
Yes, I am sharing it, sir.
Great. All right. Swasti, welcome.
Thank you, sir. Sorry for the technical glitch.
No issues at all. Anything from Narayan Nambudiri's group, there's so much to learn. And thank you for staying so late.
No problem, sir.
Is the slide visible, sir?
Yes.
Good evening, everyone. I'm Dr. Swasti. I'm a senior resident from the Department of Cardiology, Sri Chitra Institute in Kerala. I'll be presenting a case bumped by the balloon. Am I audible?
Yes, you are very much.
At the onset, I'd like to thank Narayan Nambudiri, sir, who's the head of our electrophysiology department. I'd also like to thank all the other faculty and fellows of our department who were a great help in making this presentation. Moving on to the case, our patient was a 72-year-old hypertensive gentleman who was also documented to have mild obstructive sleep apnea. He had presented to an outside center with the complaints of recurrent palpitations on and off for the last 2 years. And it was associated with presyncope and at times syncope also. he was diagnosed as a case of paroxysmal atrial fibrillation, and he had been started on beta blockers, apixaban, and amiodarone from the outside center. But the patient continued to be symptomatic on amiodarone, and also he developed amiodarone-induced hypothyroidism. So he was referred to our center for further management. On evaluation, he had a structurally normal heart, apart from mild concentric LVH and grade 1 diastolic dysfunction. We changed his medications from amiodarone to flecainide, but the patient continued to be symptomatic. He had recurrent hospitalization secondary to AF with FVR. So can you go to the next slide, please? So our patient continued to be symptomatic on drug therapy. So he had a failed pharmacological therapy, and we gave him the option of catheter ablation, which was a class 1 indication in him, and the patient was keen on going ahead with the procedure. Next slide. As part of pre-procedure planning, we did a transesophageal echo that ruled out a left atrial as well as a left atrial appendage clot. Cardiac CT was also done to study the pulmonary vein anatomy. The cardiac CT is showing that the right-sided pulmonary veins are normally draining into the left atria, but on the left side, a left common pulmonary vein was seen. So the left common pulmonary vein is defined as if the left superior and inferior pulmonary veins join together at least 5 millimeter before the entry into the left atria. And it is quite a common anomaly that is detected in patients undergoing cryoablation, seen in about a quarter of the patients. Some studies have told that the presence of anatomical variants such as these could lead to higher rate of AF recurrence on follow-up, but that is again controversial. Left common pulmonary vein was noted on the left side. Next slide. We also studied other pulmonary vein parameters like the diameter and pulmonary vein area, which was adequate in our patient. And we also studied indices like the eccentricity index, which was suggesting that the pulmonary vein ostia in our patient was circular rather than oval, and this was overall favorable. The left atrial volume index in our patient was around 38 ml per meter square, which indicates that his LA size was moderately increased. And after the pre-procedural planning, we went ahead with cryoablation. Next slide. Okay. So I put up this picture to show the catheters that we used. So 4 venous accesses were used. Can you please click next? So the coronary sinus decapolar catheter was inserted via the right internal jugular vein. And through the left femoral vein, we inserted the His catheter as well as the ICE catheter. And through the right femoral vein, initially a long sheath was inserted containing the Brockenbrough needle, which was used for septal puncture. This was later replaced by a flex cath through which the mapping catheter as well as the Arctic front advanced balloon were later inserted. Next slide. So we went ahead with the procedure. The basal intervals were recorded and it showed a normal AH as well as HV interval. The sinus cycle length was 1100 milliseconds. We started with mapping the left common pulmonary vein. As per standard protocol, we always start from the left superior, followed by left inferior, followed by right inferior, and finally right superior. So we had a left common pulmonary vein. So we started with mapping the upper division of left common pulmonary vein. And here we can see that the Achieve catheter in the pulmonary vein has recorded some pulmonary vein potentials. Next slide. After this, we map the lower division of left common pulmonary vein. Here also we can see that the Achieve catheter has documented pulmonary vein potentials. So this video is showing the mapping catheter, which has been placed in the left common pulmonary vein. So the most common complication that is encountered during cryoablation of the left-sided pulmonary veins is injury to the esophagus, leading to an atrioesophageal fistula. So here we can see in the video, the esophageal probe of the patient is being pulled up to the location of the cryo balloon so as to closely monitor the esophageal temperature. We can also see the mapping catheter placed in the left common pulmonary vein. The balloon has been inflated here and we went ahead with cryoablation. Next slide. So we can see the Achieve catheter is not recording any more potentials, indicating that there was successful cryoablation on the left side. Next slide. So after this, we moved on to the right side and we started with mapping the right inferior pulmonary vein. And we can see here that the Achieve catheter is recording certain pulmonary vein potentials. So the most dreaded complication while ablating the right sided pulmonary veins is injury to the phrenic nerve that can lead to diaphragmatic palsy. So this has to be closely monitored. In order to monitor for this, what we did was we placed the His catheter into the superior vena cava, where it would stimulate the phrenic nerve and cause diaphragmatic contraction. So the phrenic nerve palsy or phrenic nerve injury can be monitored by placing a hand on the patient's abdomen and feeling for the diaphragmatic contractions while you're pacing the diaphragm. Or or another thing is fluoroscopically, you can watch for the diaphragmatic contractions. Or here the vector of the lead one has been changed of the surface ECG such that the compound muscle action potential is being recorded in lead one. So we can closely monitor this as well and look for any reduction in the CMAP in lead one, which could indicate that the phrenic nerve is getting injured. So the first video is showing the mapping catheter that is placed in the right inferior pulmonary vein. Our patient had some eventuation of the right-sided diaphragm, and we can see here that the diaphragm is getting paced. And if you notice that the His catheter is not inside the heart anymore, it has been placed high up in the superior vena cava. In the next video, we can see that the balloon has been inflated, and before starting cryoablation, we have to ensure that the seal is proper. So here contrast is being injected into the pulmonary veins to ensure there is no leak. After ensuring there is no leak, we can go ahead with cryoablation. Next slide. So here we can see the Achieve catheter is not showing any pulmonary vein potentials, indicating a successful cryoablation of the right inferior pulmonary vein. Next, we went ahead with the right superior pulmonary vein mapping. We can see potentials being recorded in the catheter in the pulmonary vein. Next slide. And successful cryoablation shows disappearance of potentials. So the goal of cryoablation is to ensure complete isolation of the pulmonary veins, all 4 pulmonary veins. In order to ensure this, we have to demonstrate entry block as well as exit block. So after the procedure, we try to demonstrate entry block by pacing from the CS catheter. We can see there is pacing from the CS catheter at the rate of 700 milliseconds cycle length, and potentials are not seen in the pulmonary veins. So entry block was demonstrated in all 4 pulmonary veins. Then we went ahead with demonstrating exit block. So for this, we were pacing with the Achieve catheter in the pulmonary veins, and we look for conduction into the atria and the ventricle. So while pacing from the right superior pulmonary vein, we could see that it was getting conducted into the atria and the ventricle. So we can see 1:1 conduction after the pacing in the pulmonary vein, indicating the absence of exit block in the right superior pulmonary vein. So we plan to go ahead with a repeat cryoablation of the right superior pulmonary vein. Next slide. Here, the mapping catheter in the RUPV is again showing isolated firing of the right upper pulmonary vein. Next slide. So the 3D activation mapping showed that the potentials were localized to the anterior aspect of the right upper pulmonary vein. So we tried to position the balloon in such a way, and while we were positioning the balloon more anteriorly, it was seen that there was spontaneous disappearance of the pulmonary vein potentials in the EGM. Here in the video, we can see the mapping catheter in the right superior pulmonary vein. The balloon has been inflated and we were positioning the balloon. Next slide. The disappearance of pulmonary vein potentials is more clear here. So we thought it was likely a bump termination of the pulmonary vein potentials during the position of the cryo balloon. So such a mechanical trauma induced by positioning of the ablation catheter has been documented in other arrhythmias like AV inartes, ATs, and ventricular arrhythmias. But using a cryo balloon, it had not been documented before. So even though there was a disappearance of potentials, we went ahead with cryoablation in order to consolidate this. Next slide. So a repeat cryoablation was done in the right superior pulmonary vein. The freeze artifact can be seen in the Achieve catheter. Next slide. And after the cryoablation, again, we try to demonstrate exit block in the right superior pulmonary vein by pacing from the Achieve catheter. Here we can see there is no 1:1 conduction. So here we were pacing at the cycle length of 700 milliseconds at a lower rate, and 1:1 conduction was not there, indicating that exit block has been achieved in the right superior pulmonary vein. Next slide. So this is the pre and post procedure 3D activation mapping. Post procedure, we can see there is loss of potentials in all 4 pulmonary veins, indicating a successful cryoablation. Next slide. So this was the final ECG of our patient showing sinus rhythm. Next slide. So I'd like to conclude by saying complete isolation of all 4 pulmonary veins is the goal of any cryoablation. And in order to ensure this, it is important to demonstrate exit block even after the entrance block has been demonstrated. So initially it was believed that demonstration of entrance block was enough. And if entrance block was demonstrated, usually it indicates a bidirectional block. However, subsequent studies have shown that in patients, even after the entrance block has been achieved, some patients continue to have the exit of impulses from the pulmonary veins to the atria. So this makes it important that we ensure both exit block as well as entrance block after cryoablation. And termination of arrhythmias by mechanical trauma has been demonstrated in other arrhythmias, and but never before with a cryoballoon to the best of our knowledge. So which is why we thought this was an interesting case to present. Thank you, everyone.
Thank you, Dr. Swasti. You and your co-fellows really must have made Narayan Nambudri's heart swell with pride. And not only that, you demonstrated that you were a smart EP fellow, but we could know how great the teacher Nambudri is. Every one of you from your institute presented so very well. So, I mean, the preparation, what you have made, it is meticulous. I'm so glad that your institute participated so overwhelmingly. So I'm grateful to all your co-fellows and you, and of course Nambudri. Nambudri is an exemplary teacher. So let's start with some comments from the moderator. Shomu Bora, please.
Yeah, I echo your thoughts on having Chitra. As an ex-Chitrite, I always am proud and will always be proud, and had Dr. Nambudri with us at that point also. Going ahead with the discussion, I would say 2 things. One, if you know that you have a left common pulmonary vein with a size of 26 and you have a right pulmonary vein with a size of 15, would you go ahead with a cryo or you would have second thoughts? One, and if you go ahead with a cryo, the balloon sizing, how would you choose?
So presence of a left common pulmonary vein would not deter us from going ahead with a cryoablation, because presence of a left common pulmonary vein is quite a common anomaly that is documented in that has been documented in around 25% of the patients who undergo cryoablation. And though some of the studies have shown that presence of anatomical variants could lead to a late recurrence in AF, this is still controversial. Many of the studies show that it is not an important factor. If a left common pulmonary vein is present, or if a common pulmonary vein is present, then we would have to go ahead with using a larger balloon size for cryoablation.
Hey, Vivek, welcome. You know what? I was just thinking that, we would miss you because you are going ahead of the school and you are having a nice time without us, right? In Delhi. But you know what? How nice to see you on board here.
Thank you. It's mutual.
So I hope you went through
I did.
Oh,
So
great.
I mean, it's a flawless presentation, and obviously Dr. Nambudri is super. But is it still possible to project those slides, the last 2-3 ones?
Of course, yes, Sangeet.
Because certain things I wanted to, show to the fellows.
Yes.
In that, and that's what. So can you go back slides to yes? So your the next slide now. No. Keep on going ahead. Yeah, you can keep on going ahead. Yeah. You can show the blocks. You can go ahead further. Yeah. No. I mean, you move ahead, please. Yeah. Yeah, go ahead again. Further. Yeah. Okay, just show the exit, and then there is still the exit block is not there. Just show that first. Yeah, so entry block is there, and so the entry block has usually been taken to be a surrogate for exit block. But we do know that this doesn't happen, and a lot of this has to do with the fact that so much ablation, whether it's thermal or it's because of cryo, causes edema. And because of that, sometimes, the exit blocks will not happen despite there being an entrance block. So go to the next slide. Yeah, and this is what you did correctly, absolutely, that pacing from within the vein is still capturing, and ultimately our intention is that something which is coming from inside the vein should not go outside.
Yes.
And then the next slide. Okay. So, Dr. Swasti, what is your view about this isolated firing? What does it indicate?
Sir, it indicates that potentials are still coming from the right upper pulmonary vein, and there is still some existing connection between the pulmonary vein and the atria, which is why these potentials are able to enter the atria as well, as has been demonstrated by the absence of exit block.
So are they, right now you can see these potentials, maybe in the second complex, the fourth one, and then the sixth one, right?
Yes, sir.
Do you think they're entering the atrium?
Not clear in this one, sir.
So for example, in the,
Yes.
When we say isolated by itself, that means that there is a sleeve which is still active inside, and that makes sense. You are not trying to extinguish all the fire within the pulmonary vein, but isolated PVPs by themselves have always been taken to mean that the vein is isolated, in fact, right? But yes, I mean, I have seen in my own experience couple of times when I had isolated PVPs, but then the conduction came back. So there is nothing sacrosanct here per se. But as a common garden teaching, isolated firing, which is not conducted into the atria, is suggestive of the vein being blocked. So this was one point I wanted to bring out. And then can you show the map? You made
If I might just one more. Is it a entry 2:1? That is what the question would be, because it's associated very associated with the A wave also. So 2:1 conduction into the pulmonary vein, whether it can
into
be
the pulmonary vein. Yes, that's right.
Rather than isolated firing.
Yes, so that is also a possibility, because the relation of the CS electrograms to the PV potentials is almost constant. So that is obviously another thing which is possible, that these are not isolated PVPs at all. Rather, it's a 1:2 conduction, 2:1 conduction into the. And then the slide with the 3D map. Can you go there? Yeah. So the point here I wanted to make was that cryo balloon is a very powerful, it's a very, very powerful technology. What I mean to say is that it doesn't just isolate the veins, the enteral isolation. It actually also causes posterior wall to get isolated. Because the balloons are big, and both the sides are overlapping, and that's why if you can see the posterior wall in your thing, there is no voltage left. So by and large, cryotherapy, a lot of times we see that it causes not only enteral isolation, but posterior wall isolation also.
Yes,
So
sir.
thanks a lot for sharing this. It's a fantastic presentation. Thank you.
Yes,
Ullas, can I ask something? Ashish here.
No, Ashish, you know what? We are going to go on for some more time, because we are supposed to end by 10 p.m. It is like 9:30. All right. So I think we would take this forward, because this cryoablation as such versus the radio frequency ablation needs to be also be sorted out. and of course, the atrial fibrillation ablation. I think we have the experts today. Narasimhan has a experience with both of them. Nambudiri, both of them. I'm not sure about Nitish. Does he still believe in cryo? Does he do? Nitish is still around, I believe. I think we should take this discussion forward. Great case. You know what? That 2-1 entry, was a great point. That is why, Vivek, I wanted you to be coming in. You are a master into these electrogram studies. Thank you for coming. So let's start with the master, Nambudiri itself. Nambudiri, you have been doing cryo, and then you have been doing long time since the conventional RFA for AF. Now tell me, what is your message for all of us? I don't have a cryo, by the way.
Yeah, I don't have a specific message, but cryo is quite simple, and it is very clearly we can see the isolation of the pulmonary vein. When you do with the radio frequency, generally what happens is that at the end of the procedure, many times we are not very clear whether we have completely isolated in practical way. But here from an amplitude, very high amplitude signal to zero amplitude, clean pulmonary vein isolation, we will clearly know. And all these things can be done with a very limited LA dwelling time. And in this particular case, the posterior wall isolation was very prominent, which is not true in all the cases because of the common pulmonary vein was getting into the LA quite medially. That if you see that pulmonary vein picture, it is very clear. Generally, they are far separate, and we will still have a patch of active myocardium, viable myocardium in between. That is generally the case. And I think what happened, it's more than 2-1. It is more of a dissociation. Can we go through that slide? Just so stay on that. Anyway, it is, initially when we paced, there was no conduction to the pulmonary vein at all. The initial one, when we tried to show that, there was no signal in the pulmonary vein at all. But later on, there is some regeneration of the potential, and that potential pacing spike to interval was quite varying, and the potential interval was quite fixed. So it is more like a dissociation. That's what I felt. And this one question was on any other larger balloon. In fact, the latest generation cryo balloon, what we have is only 28 millimeter. And what in a large pulmonary vein, what we do is to go for a quadrant approach, sequential, by keeping it inferior tilt, superior tilt, and also clockwise, anti-clockwise rotation. We take care of all the 4 quadrants of the pulmonary vein sequentially. It works very well. We don't have to go for another balloon, which is in fact not available to my knowledge.
Narayan, I would like to learn something more from you. Whom should I send it to you for cryoablation?
Yeah, in fact, we have done 35 cases so far, around 35. I think it's 33 or 35, out of which we had a recurrence in one paroxysmal atrial fibrillation who had a previous ablation with RF also, and 2 persistent AFib. All others are in sinus rhythm, but we limited follow-up. I think cryo works better than RF in our experience. We can say only when we got from different centers. And paroxysmal AFib, it works very well. And when we do with under 3D with all these other accessories, the additional cost of putting a aux RF catheter and filling the gaps is not at all, doesn't add to the cost in our setup. So it is almost, whenever it is required, it is an add-on hybrid approach.
Narayan, is it like paroxysmal AFs, almost like normal hearts, and then 3D, and then to fill in the gaps, you have the conventional RF? Is that the approach?
Yeah, eyes, esophageal probe, and all those things.
Oh, yeah. Yeah. You know what? I think, that is what is the message to be conveyed, I think, in this meeting. So AF ablation, very selective population with a lot of expertise. Vivek, your comments.
Yeah, so I have a conflict in the sense that of late I have just been doing AF by radio frequency. I don't have access to cryo, but I've done plenty of cryo during my training. And I fully agree. I think world over, unless there are other considerations like procurement price, world over, probably a simple, uncomplicated paroxysmal AF with normal LSIs would undergo a cryo balloon first.
Okay.
Almost everywhere in the world, that would be the norm. I'm not talking about PFA and Q dots and other things. But the moment LA is large or this anatomy is a problem, there the problems arise, and then you have to be ready with a 3D and things to fill in the gap as and as you pointed out so correctly. We also, while in UK, we had a lot of experience with persistent AF also with cryo, and there are trials now that it is quite good, provided that there is no scar and the LA is not too large. So I think cryo is a wonderful technology, and definitely I think it's very, very user friendly. Because the learning curve, I believe, for radio frequency ablation is going to be much bigger and tougher, and the LA dwell time would obviously be much more in hands of inexperienced people. With experience, I think the overall time is probably not too much different between a cryo and an RF.
Right. So Vivek, just hang on. There are two more masters here. So I would like to know from Narasimhan's viewpoint, if he is around. Narasimhan.
Yeah, I think most important is the learning curve for RF is much steeper. So if you have been repeatedly doing it over a period, for example, the first cohort of patients where Dipensha had done several years ago, segmental isolation, 10 to 15 years, they are still in sinus rhythm. So they in fact used to do just lasso, segmental isolation of potentials, and they are in sinus rhythm for over 10 years. So on the other hand, the collateral damage, everything is minimized when you use a one-shot device like cryo. So if you ask a question for an experienced operator who has been operating repeatedly into LA, with the contact force, the safety has improved, and with the high power short duration, the procedure time has come down. But the learning curve is much steeper with RF compared to cryo.
But Dr. Narasimhan, I wanted to ask you, if you are using the cryo, I think you should be also good at the conventional RFA, because then only the durability of the lesions and the recurrence, durability of lesions is longer, and the recurrence rates are minimal. Agree?
Yes, the thing is, in about we have like similar numbers like Nambudri, but at least 5 or 6 patients with HCM, we have a thing of doing hybrid. Patients with large LA, HCMs, we do both isolate the veins with cryo and then touch up the other areas with RF.
All right. So Nitish, the boss. Nitish.
So, we have, obviously in US, we do a lot more AFib ablations. So, the learning curve doesn't matter because, at some point you're using RF all the time for everything, right? But in my own center, there are a couple of people who do, I've done balloons before, but I don't, they do cryo. One thing I wanted to ask, maybe Nambudri or Swasti can tell me, you were showing the esophageal probe moving, right? When you were crying around the left-sided veins. So what is your cutoff to stop? Because there is damage. Literal esophageal fistula can happen with cryo also, right?
Yeah, this esophageal probe can measure up to, not less than 25 degrees Celsius. So that is the lower automatic cutoff for the particular brand that we use. And generally it starts from 35 to 36 and comes down. Most often if it is in close proximity, then only it comes down. And once it reaches 28 degrees, we immediately stop. Not with the double tap, with the single tap only, because it is anyway anticipated problem. And often the slope of the trajectory is not very steep beyond that. We stop at 28 degrees. And almost 2/3 of the cases, it comes down up to 25 to 26. And 1/3 of them, we have seen it goes below 25 and it recovers within 1 minute. That is what we have observed. And experienced operators from USA and all, who visited us, or some of them felt that it's safe to do even up to 20 degree, but we go up to only 28 and immediately stop. And we recool only after, refreeze only after it comes back to normalcy. I mean, up to normal value 35. That's what we follow. Anything different? I don't know with other operators.
Yeah, no, I mean, I don't know about that, but I can, because I don't use cryo balloons. I don't know what these guys do. But, you know, with radio frequency, we were using temperature monitoring. But in the last 2-3 years, we have shifted to esophageal cooling. It has just been a game changer in terms of increasing your time, because you're not worried about the temperature anymore. So you just very quickly go through it. You know, otherwise you're constantly moving the temperature probe, you're giving less power, you're moving from one vein to the other. And almost every center has that. You guys cool, you know, patients who come in with cardiogenic shock. So it's the same device. You have the machine. You just have to get a particular, probe to put in the esophagus to cool. So for us, that has been sort of a game changer for people. You know, there are people who are finishing the whole radio frequency lesion set in 1 hour. And you don't even have to do high power, short duration for that. So that's one thing maybe worth looking into. Then you don't have to worry about moving the temperatures up and down. Regarding paroxysmal, you know, there will be difficult ones where the connections will be bad. So I always tell the fellows, start with the right-sided veins, because to us, the right-sided veins can be easy or they can be hard. There is an area called the septopulmonary bundle. And that can be, you can do a VACA and you can still have to go inside. Just like in the left side, you have to go for the ligament of Marshall. You know, you can do a good VACA, no gap, but the vein is not gone, right? The right side, and not only that, it can have connections from the SVC. So those things you will not be able to pick up, you know, because you don't have a high definition catheter inside to pick up. If you put a grid, you will pick up a lot more signals. Like in this case, you were showing, you had dissociated potentials, but you still had exit block, right? So there is some signal somewhere else which is connected, not the one which is dissociated and going, which only that will pick up. So that is my only thing. For us, it becomes a cost issue, because if you're using two, but if you have a bundle deal where if you're using cryo, you can bring out radio frequency and it doesn't cost more, then I agree. I think you can quickly do the veins with the cryo, with any balloon. And then, you know, use the radio frequency for gaps, or if you have to map, you know, things like septopulmonary bundle or otherwise.
Important points. Apart from this septopulmonary bundle and venoatrial connection, what we generally have observed is that an additional small pulmonary vein, right middle pulmonary vein, generally cause a far field signal or a significant signal in the right inferior or right superior. And because of the pre-procedural 3D delineation of the pulmonary vein anatomy, we have tackled this in a couple of cases. And another one regarding the cooling, generally the temperature comes down beyond 90 to 120 seconds. By that time, in almost all these cases, we would have already isolated. And by giving an additional stage, I mean, after the isolation of other pulmonary veins and coming back to once the temperature is normal, we can safely apply around 180 to 240 seconds cryo in that, even with the close proximity to esophagus. That's what we observe.
So Nitish, I have a question for you. Why don't you do cryo?
I'm very fast with the radio frequency, and also I think I tend to, like I was saying, I tend to use this high definition catheter inside. It can not only that, it can also give you these OT vectors. It can show you exactly where things are going in from. So I just, I don't like putting a very huge big sheath inside the left atrium.
Or do you believe?
I don't doubt that it is quick. I tell my fellows who are going into practice, I tell them that, you know, if you're going to do paroxysmals, then you'll be probably fast. You can do 3-4 in a day.
See, so the teacher in you would like to pursue RF ablation for AF. I understand now. So as Nambudri was telling, I think there may be a subset of patients where cryo could be the primary modality, but then be ready with RF ablation And with all that gadgets, 3D, I think helps, eyes helps, etc. All right, so ladies and gentlemen, let me tell you that the Dr. Swasti S. Kumar's technical glitch actually was a blessing in disguise. That happened to be the last of the presentation, which actually brought up so much of a discussion about the cryo versus RFA, because in the last few years, cryo has been introduced into the country. So we are coming to the end, but I wished it went on long. It's just that it's a very odd time to extend. First of all, Nitish, you had been so very kind all these years. I'm sure you are going to be extending your support to us in future too. Thank you so very much for staying back. And I am grateful to all the faculty who had moderated so very well. They took off their time. I remain grateful to all of you. And Nambudri, I mean, what an exemplary teacher you are. I mean, like so many of your fellows presented such great cases. Every single case, I'm sure I learned, and all the attendees, I'm sure they're all benefited. Nambudri, hats off to you. And Vivek, I knew that you cut short the Saturday party and then you joined us. Thank you. Shomu, Ashish.
Thank you so much.
Yash, Narasimhan is still around, I think. So from my side, big namaste and thank you so very, very much. And you people make this particular summit bigger, and each year it is growing. This time I could notice that, you know, almost like 50 to 60 was the attendance, and 20 presentations we have for this summit, 10 over. And then we look forward to all of you to attend this on 30th, again the same time. Until then, thank you and have a great time. Bye-bye.